Good morning to you all and
Bienvenidos
welcome.
todos, ya están conectadas más de 1000
Welcome.
personas, doctor.
We have
Bienvenidos a este
more than
espacio de juntos
1,000
por el
people
Día Mundial de la
connected, and
Hipertensión.
welcome to this
Si
space
quieren
for
poner
Hypertension
de
Day.
dónde se están
You
conectando
can write
únicamente
in
la
the
ciudad donde
chat
ahí para que puedan verse reflejados en
where
este
you
mapa.
are connecting from so
Bienvenidos,
that you
qué
can see
gusto verlos a
yourselves
todos.
reflected on this map. It's a
Doctor,
pleasure
¿qué
to see
tal?
you all.
Más de 1200 personas ya
Doctor,
conectadas de
more
México,
than
Bolivia, El
1,000
Salvador, Lima.
people connected. Mexico,
Excelente,
Bolivia, El
excelente,
Salvador,
Mariana.
Lima,
Así
Chile.
que eso, le estamos pidiendo
Excellent,
a todos que
Mariana.
coloquen
We are
su
asking
país. Si quieren
everyone
verse
to write
reflejados en el
down
mapa,
their
tienen que
country. If you
colocar su
want to
país.
see
Y en
yourselves
los
on the
países que
map, you
más
have to write
personas
down
tengan se
your
van a ver más
country.
intensamente. Así que
And
Chile
the
parece que
countries
va
that have
llegando
the
va
most
ganando la
people
batalla. Wow, Chile,
will
demasiado de Chile, ¿no?
become more
¿Quién
intense
está
in terms
ganando
of
la batalla?
color.
Pues tenemos
It
en
looks
Europa,
like Chile
tenemos de
is winning the
África,
battle, but
tenemos
we
de
have
Japón,
people from Europe,
tenemos Estados Unidos,
Africa,
Canadá.
Japan, the United
México
States,
tiene un montón
Canada,
de gente
Mexico
también, pero
has a
Chile
lot of people as
está
well,
ganando
but
la
Chile
partida, ¿no?
is
República
winning
Dominicana se va
by far.
arrimando,
The
¿sí? Así
Dominican
que,
Republic is
y ahora mismo,
also
Mariana, ¿no? ¿Verdad? Tenemos
moving
1.200
fast,
participantes
and
dentro
now
de
we
la sala
have
ya y siguen
1,200
entrando más
participants
personas.
in the room,
Hemos
and
acabado
more
de abrir la
people
sala,
keep
así que le estamos dando
coming
la
in.
bienvenida al webinar de HAR en las
We want
Américas,
to
hoy
welcome
dedicado a
to
HAR.
this
Perfecto,
Hearts
Sara Mariana,
webinar
contigo.
in the Americas.
Gracias, gracias, doctor. Bueno,
Thank you
solo
very
algunas
much,
recomendaciones para que
Doctor.
podamos
I
tener
have
este
some
espacio lo más
recommendations so that
dinámico
this
posible.
session
Los
can
invitamos
be as
a que
dynamic as possible.
usen el chat
We invite you
para
to
todos
use
sus
the chat
comentarios, todas las
for your
felicitaciones,
comments, for
cualquier
your
saludo que quieran enviar.
congratulations, for
Y
any
también recuerden que tenemos las
greetings that you
reacciones,
want to
bienvenidas todas
send.
esas que
We
estamos
also
viendo.
have the reactions. It's great to see
Y
all those
tenemos
reactions.
interpretación
And we
simultánea.
have
Tenemos
simultaneous
español,
interpretation
inglés
in
y
Spanish,
también
in
tenemos para
English,
ustedes
and we
interpretación de
also have
portugués. Entonces,
interpretation
un
in
gusto tener a
Portuguese
todos
for
los
us,
de
for you.
Brasil. Ahí se están viendo
It's a
ya en el mapa,
pleasure to have
doctor.
everyone from Brazil,
Y
and we can
ahora,
see you on the map.
muchas gracias, Libardo. Si nos puedes poner la agenda para que el doctor pueda
Libardo, can you
presentarles
please
a nuestro
put
querido
the agenda on the screen
co-moderador
so
del día
that
de hoy.
Qué
the
qué
Dr.
bueno,
Ordonez
Mariana,
can
¿no?
present our
Le estaba pidiendo a
co-moderator
todos que
today?
pusieran allí sus
Great,
países.
Mariana.
Ahora
Uh,
vi que hubo una avalancha de
People have
panameños
put
que
their
entraron junto a la sala,
countries.
así que
I
Panamá
can
está
see a lot of
entrando,
people
California está
from
entrando,
Panama, an
México
avalanche of
también, así
people
que
from
tenemos
Panama.
allí, tenemos
It's
mil
great to see
cuatrocientos
you. We
participantes, no
have
hemos comenzado todavía,
1,400
así que esperamos
participants
que
and
la
we haven't
sala se
started
mantenga
yet.
abierta y
We hope
que
that the room
entonces
will be
en la
open
segunda
and
tanda de
more people to come in.
identificaciones, yo le voy a pedir que además digan sus nombres, ¿sí?
I am
Bueno, ahí
also
Salvador,
going
El
to
Salvador
ask
nos
you
está
to
haciendo
write
trampa
down
porque
your
hay un
name.
montón de gente de Salvador que ha puesto Salvador, 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 Salvador.
Salvador is cheating because
Entonces,
there's a lot of people in El
sí,
Salvador
pero
writing
salvadoreños
Salvador,
son
Salvador, Salvador, Salvador.
de los más entusiastas con la
Yeah,
implementación
people
de HAR,
from
así
El
que no me queda
Salvador
ninguna
are
duda que
very
tengamos
enthusiastic when
gente
it
de
comes to
Filipinas.
hearts
Bueno,
implementation, so I
queremos
have
que
no
esto
doubts
salga
about this.
ahora
We also
para
have people from the
empezar a darle y que
Philippines.
la gente se vaya posicionando. Pero yo creo, Mariana,
Okay, I
como la gente
believe,
va entrando a la
Mariana,
sala, ¿por qué no le vas
that
explicando un poco
while we
cómo
wait for
funcionan los
people to
botones
come
en el
into the
Zoom, por si
room,
acaso alguien
you
no
can explain to
está
them how
bien
the
inscrito para
Zoom
esto?
button
Perfecto, claro que
works.
sí, doctor.
Buttons
Bueno,
work.
recordarles a
Yes, doctor.
todos
I
que
want to
nosotros
remind
tenemos
everyone that we have
disponible el chat aquí en las
the
opciones
chat available here in the options.
que pueden ver en su menú inferior.
These are the options
Pueden
available in the
también
bottom menu. You can also
ponernos todas las
write down
reacciones
all
que
of
quieran
the
compartir.
reactions that you would like to share.
Ahí igualmente pueden poner todas las reacciones que ustedes quieran.
Yes, you can
Y
write down your reactions.
recordarles
And we would
nuevamente
like to
que
remind you
tenemos
once again
para ustedes
that
interpretación
we have interpretation
simultánea
for you,
en español e inglés.
simultaneous
Denle clic
interpretation.
sobre ese mundito que van a ver ahí abajo y también,
You
sorpresa, en
can
esta
click on
ocasión
that
tenemos
small world that you see down
interpretación
there.
en
And
portugués
we
también.
also have
Un gusto
interpretation
tenerlos
into Portuguese.
a todos por aquí.
It's a pleasure
Entonces,
to have
sin
everyone here.
Mariana, muy bien, muy bien. Me está
Very well,
diciendo, yo
Mariana.
voy a presentar al
I am
co-moderador, que
going
va a ser
to
una de las grandes
present my
sorpresas de este webinar,
co-moderator. This is one of
¿sí?
the
Pero me han dicho
great
que tiene la
surprises of
cámara
this webinar.
deshabilitada, así
But
que
they have told me that
en
his
la cámara de
camera
todos, por
is
favor, yo
disabled. So
voy a presentarlo. Si me dicen
hold
que ya
camera,
tengo la
please.
cámara
If they tell me
mi,
that
mi co-moderador en esta
If they tell
sesión.
me that
Aquí
this
está.
camera has
Bueno,
been
bienvenidos
enabled,
y
hey,
bienvenidas
here
al
he is.
webinar de Heart en
Welcome
Latinoamérica
to the
dedicado a
Hearts
Heart
webinar in
2.0. Yo
the
le doy la bienvenida.
America.
1.600 personas tenemos en
I
la
am
sala en este
welcoming
momento,
1,600
de un
people
montón de países de la
in the
región
room
y también
from a
fuera de la
lot of
región. Así
countries
que
in the
muchísimas
region and
gracias.
also from
Yo
other
tengo el
parts of the
gusto, el
world. So
honor de
thank you very
presentar
much. I
a
have the
nuestro
pleasure
co-moderador
to
del día de hoy,
introduce
el doctor
our
Paul Munder.
co-moderator,
Es el
Dr.
editor en
Paul
jefe
Munther.
de
He is the auditor in chief
American Journal of Hypertension, una de las
of
revistas
the
más
American
prestigiosas en
Journal
el
of
campo de la
Hypertension, one of
hipertensión
the
en el
most
mundo. Y el
prestigious
doctor Munder
magazines
nos
in the
va a
field of
estar
hypertension. And
acompañando.
Dr. Munther
Es
is
una de
going
las figuras
to
también
be
más
with us.
relevantes en la
He is
investigación de la
also one
hipertensión
of
en
the
el
most
mundo, así
relevant
que en
figures
ocasión
in
del Día
hypertension
Mundial de la
research in
Hipertensión,
the world.
quería darle
So
el
to
bienvenida.
celebrate this day,
Paul,
I
te paso
wanted
la palabra, por
to
favor, para que saludes a la audiencia.
welcome him. Paul, the floor is yours to say hello to the audience.
Thank you, Dr. Ordonez, and good morning, everyone. I'm honored to be joining everyone for this very important event. World Hypertension Day is observed every May 17th as part of Hypertension Awareness Month, raising global awareness about high blood pressure, promoting prevention, detection, and control, and encouraging action at individual, community, and health system levels. As everyone here knows, hypertension remains a leading preventable cause of premature death worldwide, and you'll be hearing about this throughout today's webinar. On behalf of the American Journal of Hypertension, I'm grateful for all the work that everyone here does in terms of clinical care, prevention, research. The American Journal of Hypertension aims to publish high-quality, peer-reviewed research covering basic clinical and population-level studies to improve the understanding and treatment of hypertension and cardiovascular disease. We see the American Journal of Hypertension as a key forum for scientists and clinicians focusing on evidence-based research that impacts patient care. Lastly, I just want to note that in the American Journal of Hypertension, we're honored to have published recent work from Hearts on translating guidelines, protocols, and the care pathway for hypertension into effective program implementation. And so you'll be hearing more about this today, but please visit the journal for important work on how we can translate our research findings into improving patient outcomes throughout Latin America and around the world. And with that, I'll turn things back over to Dr. Ordonez.
Thank you so much, Paul. Muchas gracias, Paul, por estas primeras palabras de la
Thank you
audiencia.
very
Tenemos
much, Paul, for
1.800
these
participantes
first
ahora
words.
en la
We have
sala. Esperamos que
1,800 people connected in
apenas
the
llevamos
room,
10 minutos con la sala abierta, pero estoy
and
seguro
it's
de
been
que vamos
just
a
10
tener más
minutes with with an open
participantes.
room, but I'm sure that we're going to have
Momento de
more
interacción que ustedes saben
participants.
que siempre nos gusta muchísimo con la audiencia,
We
les
love
voy a
to
pedir
have
que
this
además de
moment
los
of
países pongan sus
interaction with
nombres
the
y así
audience.
podemos
I'm
identificar
going
algunas de
to
las
ask you
personas que
to
están
write your
aquí, ¿verdad?
names
Y podemos
next to your
llamarlas con su
country's
nombre y
name
saludarlas,
so that
porque
we
hay
can
varias
greet
personas
people and
que
call
han
people by their
estado
names
muy atentas a
because
lo que está pasando y nos
several
han
people
pedido
have been very
saludos y nos han
attentive to
pedido
what
que
has been
transmitamos el
happening and
mensaje.
they
Entonces
have
yo quisiera hacer eso. Bueno, viene la primera
asked
parte
us
que es
to
la gran
greet
sorpresa
people and
del
send
día de hoy, que
some
incluso
messages.
no estaba Paul, no la teníamos en la agenda. La
We
sorpresa que
have a
vamos a decir
great
ahora.
surprise
Y para
today,
esa
and
sorpresa
it's
yo
not on
tengo
the
el honor,
agenda.
el placer,
And
tener
for
el
this
honor, perdón, el
surprise,
placer de presentar
we
al
have pleasure
profesor
to introduce
Gianfranco
Professor
Parati.
Gianfranco
Profesor
Parati.
Gianfranco Parati es una
Professor
de
Gianfranco
sus más
Parati is one of
referentes de
the
la investigación
highest
en
voices of
hipertensión en el mundo y es
research
el
in terms of
presidente de la
hypertension in the
Liga
world, and he
Mundial
is
de la
the
Hipertensión.
president of
Ha
the
tenido la
World League for
amabilidad y
Hypertension.
el
He
honor
has had the
nos ha hecho el honor de estar con nosotros
kindness
hoy
to be here
aquí
with.
en uno de los tantos webinars que el profesor Parate tiene que estar celebrando en estos días porque es el Día Mundial
This
de la
is one of
Hipertensión y
the
es nuestro
many
líder mundial
webinars
en
he
este
has
tema.
to attend
Así que le voy a dar la palabra al
because there are
profesor
many
Gianfranco
webinars these
Parati.
days, and
Estén
he
todos
is a
muy
leader in
atentos.
this field.
Agarren ahí el control debajo donde digan las reacciones para que puedan
I'm going
responder a
to
lo que
give
va a
him the
hablar el doctor
floor
Parati en este
now,
momento.
and
1,9,
please
tenemos
respond from
1.900
to what he is
participantes en la
going to
sala,
say
Paul,
through
en
the
este
chat.
momento. Así que
We have 1,900 participants in the room now, so this gives you an idea of the interest that people have for
Thank
this
you,
event.
Pedro, for the invitation. I'm very happy to be with you today. That's a surprise also for me when you invited me. And I'm very happy having this possibility to give you a couple of announcements that will just be introducing your meeting. May I have my slides, please? Okay. I just want to confirm the important collaboration between POW and the World Hypertension League in fighting hypertension. We are approaching the World Hypertension Day, and as you remember, the motto this year is controlling hypertension together. And this is what we are doing. POW and WHL has been working for many years together. Next, please. Next slide. And what we are facing is something summarized by WHO in the report published last year. As you remember, there was, again, clear evidence that hypertension remained the #1 silent killer in the world, affecting more than 1.4 billion people in the adult age, having only 320 million control, which is highlighting our failure. In this figure that you know very well, the different colors refer to the different regions of the world. The thick line refers to the prevalence of uncontrolled hypertension, while the thin part of the slide is indicating the smaller percentage of people having blood pressure control. The blue line refers to the Latin American countries. You see, we have a lot of work to do together. Next, please. So what is WHL doing to face this situation? First of all, we are promoting accurate blood pressure measurement with validated and affordable devices. Next, we are also promoting the need for an affordable approach to cardiovascular risk assessment. We need to implement effective but simple and affordable strategies for treatment, including lifestyle changes and pharmacological treatment. And then we need to define strategies for the long-term follow-up. This is a key issue, as you know, because many of our patients are not continuing treatment over time. Adherence is very low in the world. So we need to provide support, digital health solution, single pill, dual, triple combination to facilitate this. And this has to be done next by considering also an equitable availability of both drugs and devices. And this has to be done by involving primary care. So these are the plans that WHL is developing in this direction, which is very closely online with the programs we are proposing for the World Hypertension Day. Last year, the motto was measure your blood pressure accurately, control it, and live longer. We keep this message as very important, obviously, but this year we have decided to focus on something more comprehensive, and the suggestion is controlling hypertension together, which is including all what I've said before. Next, and this is what is being promoted by WHL by focusing on the need of teamwork. So we need to provide indication to facilitate collaboration between different people involved in hypertension care, not only doctors, but also nurses, also community workers, and also involving the patients directly, suggesting the availability of drugs and devices for accurate measurement and proper treatment. Next. And also we need to combine the efforts done with other associations. And the HEARTS program is exactly focusing on what I've said before. So you can see immediately how close is the cooperation between the World Hypertension League and the POW promoting the WHO HEARTS program. And in this meeting, you will be hearing a lot. So WHL has decided to support people working in this direction. Every year, we are offering awards to people that have been excellent in promoting better hypertension control in the world. And I'm very happy to announce that this year, next slide, we have presented the Liu Lisheng Excellence Award in Population Cardiovascular Risk Factor Control in Low and Middle-Income Countries to Dr. Barbosa da Silva, who is the president of POW, which is emphasizing the important contribution he has done in this direction. Next, please. You know Dr. Barbosa very well, but let me just summarize the importance of his activity. He has dedicated his entire life to public health, being also involved in Brazil with the Ministry of Health. He was vice minister and was covering many other roles very important to promoting a better health. Next, please. He has also been involved in a number of international activity, coordinating several implementations activities for focus on infectious disease, non-communicable disease, working with WHO and another group of international association. This was also coupled by many lectures and many interventions in webinars and seminars, promoting always better healthcare, disease surveillance, and prevention of infection and chronic diseases. So he did a lot of work in this direction. Next. He became director of the PAO in 2023, and since then he has been closely working also with WHL and other associations to promote what I've said before. And in particular, the hearts in the Americas is a good example of how energies can be combined to promote a reduction in cardiovascular risk through the control of risk factors, and in particular hypertension. So Dr. Barbosa certainly deserves this award next, and I'm really very happy to announce that this is an example of what we should see in many countries. This award is stimulating other people to do the same in different regions of the world, and we are all very grateful to Dr. Barbosa for his important contribution. Finally, next slide, please. I just want to invite you to the World Congress, the 7th World Congress that we are organizing next year. It was in Latin America, it will be in Brazil, in Goiânia. The main theme of the Congress will be facing hypertension without borders and promoting better blood pressure control for cardiovascular risk reduction globally. So you are really all invited to contribute to this Congress, to join us in Goiânia. There will be May 13 to 15 next year. And my final slide, please. I just want to conclude that given that we have to face hypertension still remaining a stealth killer, next, we need to do this by, of course, controlling hypertension adequately, by a focused intervention on cardiovascular risk reduction. With the early intervention, we need to be fast in controlling hypertension before organ damage develops and hypertension may become resistant. And this is supposed to be based on accurate measurement and monitoring, but also changes in lifestyle, personalized treatment, and in the end, focus on our patient with all comorbidities. So let's work together, and that's my invitation, and try to reduce together the burden of cardiovascular disease worldwide. Thank you again for your invitation. I really wish you a fantastic webinar today, which is associated with the World Hypertension Day. And let me thank again Andres and Pedro for inviting me to be with you at least for a few minutes. Thank you so much.
Muchísimas gracias, profesor Gianfranco Parati. Como siempre es un
Thank you
placer
very much, Dr. Gianfranco
tenerlo
Parati.
aquí.
It is always a
Voy a
pleasure
responder las
to have you
preguntas antes de
here.
pasarle la
I'm
palabra a
going to
Paul,
respond
¿sí? De lo que
to
significa el
the
día y de lo que estamos viviendo. En primer lugar,
first question.
nos da mucho gusto anunciar
In
que
the
vamos a
first
estar
place, we are
apoyando el
happy to
Congreso
announce
de Goiânia en
that
Brasil, seguro sí o sí.
we're going to
Nuestro
be
equipo,
supporting
aquí
this
están los
Congress in
brasileños mandando
Brazil and
mensajes para que
Guyana.
les diga que estamos
Brazilian
aquí. Los
people are
brasileños
sending
van a avanzar en la implementación de HART. Así
messages that say that
que
Brazilian people
quería
are going
decirle
to
eso y estamos
advance in the
preparados.
implementation of the
El
HEARTS
World
Initiative,
Hypertension League
and
nos dio el honor,
the World
Gianfranco, quiero agradecerlo a
Hypertension
nombre de todos
League
colegas, de
has
tener
given
una
us this
sesión completa
honor to
dedicada en el
have
World
a
Congress
complete
of Hypertension,
session in
dedicado
this
a trabajar
World
en las Américas,
Congress
así que eso va a ser
for
un
hypertension to
momento de
hearts in
mucha
the Americas. So
reflectología.
it's going
Esperemos
to
que
be
los
a
países
very
líderes
nice
de la implementación
moment.
de HART estén en Goiânia, en Brasil, el año que viene, compartiendo las experiencias con la comunidad de
And
países que
we
hacen HART. Así que
are
yo, en primer
happy
lugar,
to
quiero
share this
agradecer
initiative.
al
So in the
profesor
first place, I want
Gianfranco
to
Parati por
thank
esta
Professor
gentileza. En
Gianfranco
segundo lugar,
Parati
le voy a
for
preguntar a
being
Paul,
so kind. And now I want to ask
co-moderador,
Paul,
¿verdad,
my
Paul? Qué bueno
co-moderator,
es cuando los líderes de tu organización se incorporan,
how
¿no,
good is it
verdad?
when the leaders
A
from your
un apoyo
organization
como una organización del
join
tamaño de la OPS Nosotros tenemos oficinas en todos los
an
países de las
organization
Américas.
as
Tenemos
big as large as
países miembros en
PAHO.
toda la región.
We
Y estamos
have
muy
member
orgullosos de ser
countries from the
PAHO.
whole
Y
region, and
hoy
we're
que
very proud
la
to be
Liga Mundial
PAHO.
de la
And
Hipertensión, World
today,
Hypertension League,
the
tenga el
World
honor
Hypertension League
de decir,
has
mira, le hemos
the honor to
otorgado el
say
premio
we
al
have
director
given
del
the
OPS.
prize
Eso es
to
un
the
símbolo
director of
y un
PAHO.
reconocimiento para
That
esta
is a
región y
symbol, and that
también
is an
para los
acknowledgement
funcionarios de
for
la
this
OPS aquí
region, and
que
also
están
for
presentes, que son muchos, diciendo
officials from
apoyo y
PAHO that are
reconociendo. Paul, ¿qué te
present,
parece a ti esta?
and
¿Cómo
that
tú
are,
reaccionas a las palabras de
and there are
Gianfranco
many of them. So,
y a
Paul,
este
what is your
premio? Paul.
reaction to Gianfranco's words and this prize, Paul?
Thank you for the opportunity to comment. Dr. Prati, I've known for a long time, and I think the work that he's presented really emphasize several factors. Hypertension is the leading cause of death worldwide, including in Latin America, throughout the Americas. However, we know that it's preventable. We know it's treatable, and the data he presented, he provides a clear pathway that we can all follow for identifying the presence of hypertension and using evidence-based approaches to treat it. Now, there are some challenges I think that he points out, finding simple ways to assess cardiovascular risk, which is very important for guiding treatment. However, I think we've transitioned over the past 20 to 30 years where I think we're now focused on we know what to do, we have the evidence, and now it's about implementation. And it's really about working with communities, working with whether it's patients, community health workers, others in the community on the using the evidence we know to prevent hypertension, and when hypertension's present, to diagnose it correctly using validated blood pressure monitors, and then using very effective treatment, combination therapy, which is can be very inexpensive. And so I think it's a great way to start today to think about, once again, we're not where we were 20, 30 years ago where things were a bit more challenging. I think the new challenges are let's implement the evidence. And so I'm very excited by his presentation because it really emphasizes where we are in 2026.
Muchísimas gracias, Paul. Y entonces, para responder a este mensaje
Thank you
del
very
premio que
much,
está recibiendo
Paul.
el director de
And
la
so
OPS,
to answer
voy a
to
presentar al propio
this
director de la OPS en las palabras de
message of this
aceptación
prize, I'm going to
del premio
present Dr.
de la
Barbosa's
World
words
Hypertension Lead al director de la
and
OPS,
his
al doctor Jean
reaction
Barbosa, el
to
reconocido
receiving
director y
this
también de
prize.
personalidad de la ciencia. Adelante,
He
doctor
is
Jean
the
Barbosa.
director of PAHO and also a personality in science.
To the World Hypertension League for this important recognition. It's a great honor to receive the Liu Li-Sheng Excellent Award. I accept it not as individual distinction, but as a reflection of the collective efforts of countries, health workers, and partners across the Americas who are committed to improving cardiovascular health. I also wanted to acknowledge the leadership of the World Hypertension League and the strength of our partnership. Together, we have helped bring hypertension to the forefront of the global health agenda. And importantly, we are turning that priority into concrete action. We know that hypertension remains one of the leading risk factors for cardiovascular disease worldwide. And we also know that control rates are still too low. Addressing this goes beyond clinical care. It requires stronger health systems, reinforced primary health care, committed leadership, and sustainable implementation at scale. At PAHO, we are fully committed to advancing the global hypertension agenda by accelerating the Hearts in the America initiative. We are proud that Hearts has become the largest coordinated regional effort to strengthen hypertension control, reaching more than 11,000 primary health care facilities. Through Hearts 2.0, we are now moving forward to integrate cardiovascular, kidney, and metabolic care within primary health care, with a community-centered approach to reach everyone. As we mark World Hypertension Day, this recognition is also a call to action. We encourage governments, health leaders, and partners to strengthen their commitment to implementing standardized, evidence-based care with the primary health care at the center. We also look ahead to the World Hypertension Congress in Goiânia, Goiás, Brazil, in 2027 as an important opportunity to accelerate progress on the global hypertension agenda. Together, we have the knowledge, the tools, and the real opportunity to change the trajectory of cardiovascular disease. What we need now is scale, speed, and sustained commitment to move faster and reach further. Thank you very much.
Bueno, muchísimas gracias al doctor Barbosa, muchísimas gracias al profesor Gianfranco
Thank you
Parati
very
por
much to
esta
Dr.
novedad, el
Barbosa.
premio. Aquí usted está viendo nuestro compromiso, así que aprovecho que todos
We can
vayan
see the
entonces
prize,
a
we can
las
see your
reacciones
commitment.
y
So
pongan
you
ahí
can
las
all
reacciones
go
que
to
quieren ahora
reactions.
sí
You can all
de
go to the
celebrar el
comments
premio
box to
que está
celebrate
recibiendo
this
el director de la
prize.
OPS y los países participantes. Así que yo creo que este es un
And this is the
momento
prize that
muy
Dr.
saludable
Barbosa has
para
received, but
externar nuestras
also
emociones y decir qué bueno, qué
all
compromiso
people working at
y tenemos
PAHO
un refuerzo más. Hay que
and
hacer estos
everyone in the
programas con
community.
compromiso político
We
también,
have
¿verdad,
to
Paul
have
y
these
Gianfranco? Hay que decir,
programs
bueno,
with
tenemos
political
las
commitment.
herramientas, pero hay que
We
tener el
have the
compromiso
tools,
político
but
de los
we
líderes
must
de que esto
also
va a ser
have
una
the
prioridad. Así que
political
un
commitment
aplauso para
from
estos todos los
leaders
países que
to
hacen
make this a
HEART y a
priority.
los
So
países
this
que van en
is
la delantera. Pero
very
para
important
entrar
for countries that
muchísimas gracias,
implement
Paul,
hearts.
muchísimas gracias,
Thank
doctor
you very
Barbosa,
much,
por el
Paul.
tiempo
Thank you very
dedicado
much,
a esto y
Dr.
por el apoyo
Barbosa,
y
for the
Hardo por
time that
vosotros.
you have
Gianfranco, nos
given
estaremos
to
viendo y
Hearts
seguimos con nuestro webinar en el Día
2.0,
Mundial de la
and we
Hipertensión.
will
Ahora,
continue
presentando el próximo
discussing this
módulo,
on the World Day of
Andrés
Hypertension. Let's
Rosende es
introduce
un
the next
médico
model.
cardiólogo
Andres Rosende
que
is a
trabaja con HEART
cardiologist that works with
y ha
hearts,
estado al cargo de
and
cómo se conduce
he
HEART 2.0. Así que
has
hoy
been
nos
in
va a
charge
traer
of Hearts 2.0.
Andrés un resumen
So
de lo
Andres
que
is going
significa HEART
to
2.0. Seguro
present
ustedes han
a
escuchado ya
summary
de
of
HEART
what Hearts
2.0. Lo
2.0
mencionó el
means.
director, lo
I am
mencionó
sure you
Gianfranco,
have heard about
lo
this. The
mencionó Paul
director
hace un
mentioned this,
minuto y
Gianfranco
ahora
mentioned
vamos a
this,
ir
Paul mentioned
directamente
this a
a
minute
qué cosa
ago.
es HEART
And now
2.0,
we're going
Andrés.
to talk about
Y tú
what
nos
is
haces un
Hearts
resumen de lo que
2.0.
significa eso.
Andre, you're
Adelante,
going
Andrés
to
Rosende,
summarize
desde el
this.
equipo de
Please
HEART.
go ahead.
Muchas gracias, Pedro. Muchas gracias, Paul. Y
Thank you
bienvenidos
very
a todos los
much, Pedro.
participantes a
Thank you
este
very much, Paul, and
webinar.
welcome
Bueno, en los
all to
próximos
this
minutos
webinar.
vamos a introducir
In
el
the
tema
next
del
minutes,
webinar,
we're going to
que es este
introduce
proyecto
the
de Hearts de
topic
las
of
Américas
this
denominado
webinar,
Hearts 2.0.
Hearts 2.0, our
Y para
project in
eso,
the
yo
Americas.
quiero
And for
alertar
this,
sobre una situación,
I would
que es
like to
que
alert
de
on a
las 20
situation.
principales causas
Out of the
de carga
20
de enfermedad, quiere
causes
decir mortalidad
of a
prematura
disease load,
y
meaning
años
premature
vividos con
mortality
discapacidad, con una
and
condición
years lived with
de,
disability, with a
que
condition
altera la salud,
that alters health,
al menos la mitad
at least
comparten
half
los mismos factores de riesgo. Y esto
share the
significa
same risk
que
factors. And this means that
más de la mitad de esta carga de
more
enfermedad y
than
mortalidad
half
prematura
of
está
this
relacionada
premature
con
death
estos
load
factores
is
de riesgo
related
que todos
with these
conocemos,
risk
el
factors that we
tabaquismo,
all
el
know:
sedentarismo, el exceso de
tobacco,
peso, la dislipemia,
sedentarism,
y en el centro
sedentarism, excess
la
weight,
hipertensión arterial. Y claro, el
hypertension,
control de estos
elevated
factores de riesgo
cholesterol,
debería ser
diabetes.
el objetivo
Uh,
principal de todo programa de salud pública.
and so
Y sabemos que
controlling these
hay
risk
intervenciones a
factors should
diferentes
be at the
niveles y que hay
center
algunos
of
factores
all
de
health
riesgo como
programs,
la
public health
obesidad o el
programs.
tabaquismo o la
We know
inactividad
that there
física
are
que tienen
some
un
risk
componente muy
factors
fuerte desde el punto de
here that
vista
have a very
regulatorio y
strong
de las
component
políticas
here.
sobre la industria de alimentos, por ejemplo, o políticas para limitar el
It's very
consumo de
important to
tabaco, pero
work
hay
with the
otros
food
como
industry
la
or the
diabetes o
tobacco
la
industry to
hipertensión,
limit
que
these
como bien se dijo
consumptions.
aquí, es
But
el
there are
factor de
other
riesgo
factors
de
like
mayor peso por su alta
hypertension that
prevalencia,
have the most weight
requieren
because they are
que
very prevalent
intervenga
and
activamente
they
el
require to
sistema de salud, los
have
servicios de salud
interventions
y
from public health
fundamentalmente la
systems,
atención primaria, que es
especially
donde
primary health
atiende la gran
care,
mayoría
which
de
is
la
where
población.
most people get care from.
Y hay otra capa más de
And there
complejidad,
is another
que es que
layer of
todos estos factores de
complexity.
riesgo
All
no
of
se
these
dan de
risk
manera
factors do not
independiente uno del
happen
otro como si fueran
independently
compartimientos
from the other. They are
estancos,
not
sino que
silos or
están
compartments.
íntimamente
They are
relacionados desde el punto de
intimately
vista
linked
fisiopatológico
from a physiopathological point of view.
tener sobrepeso,
Because,
tener
for
obesidad
example,
en un estado
being
inflamatorio que aumenta la
overweight,
presión,
having an
altera
inflammatory
los niveles
state
de
that alters
colesterol,
pressure,
esto
that alters
enferma
cholesterol
las
levels.
arterias
This
grandes, las arterias
makes
pequeñas, esto impacta los
arteries sick,
riñones
the
y la
big
enfermedad
ones and the
renal,
small ones. This
luego
impacts
retroalimenta el
the
ciclo
kidneys,
y de la misma
and
manera
this
exige
feeds the cycle
el
back and
metabolismo
requires
glucémico hasta que el páncreas ya no puede responder
and
y
glycemic
empezamos
metabolism
también con
worsens, then
la
the pancreas
diabetes. Y
cannot
todo
respond and the diabetes starts.
este
And so
constructo
this
que en el pasado tuvo varios
construct
nombres, se
had
llamó
several
síndrome
names in the past. It
X
was called
plurimetabólico, síndrome
X
metabólico.
plurimetabolic
Hoy en día
syndrome.
ha
Today,
resurgido nuevamente con esta denominación
it
del
has a
tipo
new name,
síndrome cardiorrenometabólico y otros dicen, bueno, pero el hígado también afecta, entonces debería ser
Cardio-Kidney-Metabolic
síndrome
syndrome. But
cardiorrenometabólico.
also the liver
Ok,
is also
estamos de
affected, so
acuerdo
we
que el
should include it
problema
in
es
the title.
este
So we
y
agree
en vez
that
de
the
perder el
problem is
tiempo
this,
en
and instead of
poner
losing time
etiquetas, lo que
in
tenemos que hacer es
creating
evaluar
tags,
esta
we have to
situación.
take care of the
Y
situation.
yo quería traer estas
And
imágenes
I wanted to bring these
porque hasta hace nada
images
más,
because
casi 4 décadas, esta era la imagen que
until
uno podía
4
ver
decades
en cualquiera de los
ago, this
parques
is the image you could
existen en las
see
ciudades de nuestros países.
in
Era
any
donde
park
mucha
in
gente
our
joven,
cities.
muchos niños,
Mainly
muchas
young people,
familias
lots of
jóvenes con niños
children,
pequeños.
many
Y
young
tan
families
solo
with
36 años
young
después,
children, and
esta es la
only
imagen que nos
36
encontramos.
years
Entonces
later,
vamos
this is the
sumando
image we
capas
see.
de complejidad.
So
Tenemos
we add
factores de
complexity
riesgo
layers. We have
que
risk
están
factors
interrelacionados,
that are
que
interrelated,
contribuyen
that
el riesgo de morir
leverage
prematuramente
the
o de
risk
enfermar.
of
Tenemos
dying
además
prematurely
una
or
población
getting
envejecida.
sick.
Sabemos que
We
todos estos
also
factores de
have
riesgo, principalmente la
an aging
hipertensión,
population, and we
tienen
know
un
that all
incremento
these
de su
risk factors,
prevalencia a medida
particularly
que avanza la edad.
hypertension,
Y todo esto
prevail
va
as
impactando
age
y va estresando
advances,
los
and all
sistemas
this
de
impacts
salud.
and stresses healthcare
Entonces,
systems.
la
Therefore,
pregunta es cómo dar una
the
respuesta efectiva a la
is
multimorbilidad, porque
how
cada
to
vez vamos a
effectively
encontrar más
respond to
personas
multi-morbidity. We'll
más
find
enfermas
more and
y
more
con
people that are
mayor
sicker and
carga
sicker
de estos
with
factores de
a
riesgo.
greater burden
Y
of
como
these
recién
risk
mencionaba Paul
factors.
Monder,
And
estamos
as
en
Paul
un momento
mentioned,
donde
we
tenemos la
are at a
evidencia, sabemos
point
qué
in
cosas
which we
funcionan,
have
sabemos lo
evidence.
que hay
We
que
know
hacer,
what works,
pero
we know
es
what to do.
tan abrumadora el
But
cúmulo de evidencia
it's,
que necesitamos
I
de
mean,
alguna manera sintetizarla,
the
separar la
evidence
paja del
is
trigo
so
y
large,
establecer
we need
recomendaciones.
to
Aquí aparecen las guías
synthesize
de
it
práctica
and
clínica. Y las
establish
guías de práctica clínica
recommendations through
hacen esta tarea y por eso
clinical
tenemos guías
practice
de
guides.
hipertensión, de diabetes, de
That's why
enfermedad
we have
renal,
guides for
de
hypertension,
cardiovascular,
diabetes,
para la atención
kidney
del
disease,
infarto y tenemos
cardiovascular
tantas, pero tantas
diseases,
guías que
and
volvamos al centro de atención primaria de
infarct
salud,
prevention,
volvamos
etc. So
poner
this
el
is
foco en
why
estos
we
profesionales que tienen
go
que
back
estar
to put the focus on
eh,
these professionals
aguantando
who have
este
to
problema
withhold,
creciente y
withstand
rápidamente
this
vamos a poder entender
increasing
que no
problem,
hay
and we
forma
will
de
be
procesar
able to
esta información
understand
y es
that there's no
por esa
way in
razón que las
processing
guías de práctica
all
clínica
this
son
information.
un
That's
eslabón
why
necesario, pero no
clinical
suficiente
practice
para
guides
garantizar una
are a necessary
implementación
link
efectiva. ¿Por
that is
qué?
not
Porque
sufficient
las
to
guías habitualmente
guarantee
son
effective
extensivas
work because
y
guidelines are
son de abordaje
extensive
vertical. Yo tengo una
and
guía de
their
hipertensión y tengo todo lo que necesito
approach
saber
is vertical.
para
I
tratar la
have a
hipertensión arterial,
hypertension
pero
guide and
para
I
tratar
know
desde
everything I
las
need
formas
to
más
know
frecuentes
to
hasta la
treat
hipertensión secundaria
hypertension,
a
from the
a los
worst hypertension
diagnósticos
to
más
secondary
raros.
hypertension to
Y yo tomo esas
rarest
guías y
diagnoses.
armo
If
protocolos
I
basados en esas
have
guías,
these
estoy
guides and then I assemble
generando un instrumento de
protocols based
implementación
upon
que es
these
mucho
guides,
más
I'm
práctico y mucho
generating an
más razonable.
implementation
Pero si yo voy un paso más allá y esos
tool that is
protocolos
much more
pueden
actionable. If I
venir
go one
basados
step more
en diferentes guías, yo
and
puedo tomar un protocolo
realize
para el
that these
manejo de la
protocols
hipertensión, para el
based on
manejo
several guides, I can have
de los
protocols for
lípidos, para
hypertension,
la
for
medición
lipid
de la presión
management, for
arterial o
measuring
para el
blood
diagnóstico de
pressure,
diabetes y los
for
combino y
diagnosing
lo que tengo es
diabetes, and
una
then
guía
I
clínica.
combine
Es un
them.
super
Then I have
instrumento
a clinical guide, which
basado
is,
en
I'm sorry, a
múltiples
clinical
protocolos que
pathway,
están
which is an
fundamentados
instrument
en guías
based on
clínicas de alta
multiple
calidad
protocols
basadas
that
en la
are
evidencia. Y este
based,
abordaje ha sido tan exitoso
evidence-based,
que
and
ustedes
also
podrán ver cómo
protocol
los
based.
países de la región de las
And
Américas
this has
lo
been
han
so successful
adoptado
that
y
you
lo han
can see
adaptado.
how the countries have
Entonces, si
adopted
nosotros
and
sabemos que
adapted this in
funciona,
the Americas.
que
If
no
we know
funciona
this
y cuál es
works,
el problema que
I'm sorry,
tenemos
if we
delante,
know what works and what
tenemos que
doesn't
volver a esa
work and
respuesta
what
de
the problem
cómo
at hand
lidiar
is,
efectivamente con la
we
multimorbilidad.
can
Y ahí
have a
nace HART
response
2.0,
to
un proyecto que
to
está
deal
ya,
with
ya
multimorbidity. And
concluyendo
that's HARTS
con la vía clínica que
2.0,
les voy
a
a mostrar
project
en unos
that is
minutos,
concluding with a
pero
clinical
que ha
pathway
tomado
I'll show in a
más
few
de
minutes,
un año y medio y que hemos
but which
tratado
has
de
taken
conducirlo de la
more
manera
than 1 year and
más
a half, and we have
rigurosa y
tried to
representativa
lead it
posible,
in the most rigorous
dividiéndolo
and
en varias
representative
fases.
way,
La primera
dividing it
fase,
in several
donde un grupo
phases.
internacional de
The first
expertos
phase, in
evaluó
a
la vía
first
clínica
phase,
actual
an
e
international
identificó
expert group
oportunidades de
reviewed the
mejora
HARTS clinical
para
pathway,
volverlo un
suggesting
instrumento más
57
robusto para poder
improvements
dar
to make it a
respuesta
more
a
robust
este
instrument
riesgo
to respond to this
cardio-kidney-metabólico. Con esas intervenciones
cardio-kidney-metabolic
candidatas, esos puntos
risk.
de mejora,
With these
26 ministerios
improvement
de salud
points, 26 Latin
de
American
la región
Caribbean ministries of
evaluaron
health
la
in the
factibilidad
region
de implementación
evaluated the
y los
feasibility of
horizontes
implementing
para
HARTS and
poder implementarlas ampliamente en la atención
how
primaria,
to
identificando también
implement
las
this in
principales
primary
barreras,
health care,
para
also
finalmente
identifying the
con
main
estos dos
barriers.
insumos
And
hacer una
finally, with these two
revisión
inputs,
exhaustiva de la evidencia utilizando
rigorously review
metodología Gray,
the evidence by
destilando esa
using the Gray
información
methodology,
contenida en
distilling
múltiples guías
this
de alta calidad
information
y logrando
contained in
consenso
multiple high
sobre
quality
38
guides
puntos de
and
mejora
achieving
de la
consensus
vía
about
clínica metabólica.
38
Este
improvement
proyecto fue
points in
documentado
the
en
HARTS
múltiples
clinical
publicaciones,
pathway.
paso a paso,
This
y aquí ustedes podrán
was
ver
published in
la
several
fase 1, la
editions. You
fase
can see
2,
phase 1, phase
la
2,
fase 3 y
phase 3,
finalmente, que se publicó esta semana
and
en
finally, we
Lancet,
published
el resultado
well,
final de la vía
Lancet
clínica de
published the
HART
final
y
result this
estamos muy
way, which
próximos
is
a
HARTS 2.0
obtener
clinical
el
pathway.
reporte
And
técnico con
we're
toda la
about
síntesis
to
de evidencia
get
que
the
está
technical
detrás
report with all the evidence
de este instrumento que
synthesized,
estará
which is
próximo a
behind
salir.
this instrument that is about to come out.
Finalmente, ¿qué hicimos con HART 2.0?
What did we
Tomar
do
la
with
vía
HARTS
clínica como
2.0?
concepto,
Take the
tomar las
clinical
vías
pathway
clínicas
as a
como
concept
instrumento
and as
y basándonos
instruments,
en
and
el
based
éxito que tuvo la
upon
vía clínica previa,
the
avanzar hacia la
success of
nueva
the
vía clínica
previous
de HART
clinical
2.0,
pathway,
que no es nada más ni nada
progress
menos que
towards
una versión
2.0, which
mejorada que
is an
expande
improved
sus
version that
objetivos,
expands its
donde también se
objectives.
estructura en diferentes
There, we
segmentos,
also
en este caso en 4
structure
momentos, un
at
momento
different
dedicado al
points, 4
diagnóstico,
points,
otro a la
one devoted to
identificación de riesgos,
diagnosis, another
el
to risk
momento C al
stratification,
tratamiento y el
another
momento
to
D al
treatment, and
seguimiento,
another
porque
to
sabemos que si
monitoring,
nosotros
because
queremos
we know that
mejorar el
if we
control de la
want to
hipertensión, tenemos que
improve
diagnosticarla
hypertension
correctamente
control, we have
y
to
por eso
diagnose it
necesitamos un
correctly.
protocolo
And we
estandarizado,
need a
muy claro, que nos
standardized
diga cómo
protocol
hacer el
that is
diagnóstico de
very
hipertensión
clear
arterial y
and
utilizar los equipos
that tells us how to
automáticos
do
clínicamente validados para poder tener confianza en
hypertension
ese dato de presión arterial que se
to
registra.
have
Y con eso no alcanza
reliability.
si no incorporamos
And
estos mensajes
if we don't incorporate these
vinculados a
messages
desarrollar
related
estrategias
to
de
developing
búsqueda de
strategies
casos en determinadas
of
poblaciones que
seeking
sabemos que
cases
tienen
in populations
limitado
we
acceso a
know
los servicios de
have
salud
limited
por
access to
cualquier
healthcare
motivo.
services due
Para
to any
luego,
reason, we
una vez
won't
que se
be
hace el
able
diagnóstico,
to apply
pasar
all this.
a
Once
la
we do
estratificación de
diagnosis, we
riesgo. Y
need
esta
to go to
estratificación de
risk
riesgo nos
stratification.
tiene que hacer
This risk
pensar
stratification
en
has
la
to
diapositiva que les
lead us
mostré
to
hace un
think
momento, la interrelación que
about
tienen estos factores de
the
riesgo. Saber que si
slide
yo tengo un
connected
paciente
to
hipertenso, es muy probable
interconnection of
que
risk factors.
es
If
más
I have
probable que
a
pacientes no
patient with
hipertensos que tenga
hypertension,
diabetes.
this
Sobre todo si
patient will
tiene
probably have
hipertensión
diabetes,
y sobrepeso.
particularly
Pero
if
además, si
this
tiene
person is
hipertensión,
overweight
sobrepeso y
too.
diabetes, es
If
mucho más
this
probable
person
que
has
tenga enfermedad
hypertension,
renal
diabetes,
crónica.
and
Y yo,
overweight,
no pudiéndolo de
perhaps
esta manera,
also
nunca
will
voy a
have
poder detectar
chronic
estas condiciones
kidney
y
disease.
tampoco voy a poder
If I
prevenir
don't have
su
this
progresión
pathway,
hasta formas
I won't
terminales.
detect all this and
Entonces, esta
prevent
estratificación de
progression to
riesgo
terminal
tiene
forms.
que ser muy pragmática
So this
y
risk
tenemos que
stratification
darle
has to be
visibilidad
very
para
pragmatic,
que
and we need to
ante
give
la
it
presencia de
visibility
cualquiera de ellas,
so
ese
that in the
paciente sea
presence
abordado como un
of any of
paciente
these
de alto
diseases,
riesgo,
the
porque
patient
realmente
is
lo que significa
dealt with
tener
as
estas
a
condiciones
high-risk patient,
interactuando entre
because
sí.
all these conditions
En
interact
el centro de la vía
among
clínica mantenemos el
themselves.
tratamiento, pero no
In
solamente el
the
tratamiento de la
core of the
hipertensión,
clinical pathway, we have treatment, of course, not only for hypertension, but also cardio-kidney-metabolic. Hypertension is the entry point, the main problem. And that's why we continue with this standardized protocol that is linear, has intervals for increasing and intensifying doses that rules out monotherapy, one of the main barriers to reach higher rates of hypertension. Monotherapy should be the exception. There are patients who will need monotherapy. Very specific cases, very old patients that are fragile with comorbidities. All the others need to receive treatment with at least 2 drugs from step 1. If these 2 drugs are combined, much better. And when we reach step 3, we see options that combine 3 drugs. In this way, each country will be able to adapt this clinical pathway to their possibilities. And here, we are just proposing medication as an example. We have valsartan amlodipine, or you can also have valsartan amlodipine hydrochlorothiazide. So step 1, 1 tablet, step 2, 1 tablet, pass 3 and plus 4, 1 tablet, 1 tablet. To a great extent, people with hypertension, even with intensified treatment, will be able to resolve the main health problem by taking 1 tablet per day. And this is complemented with non-pharmacological treatment. Oftentimes we say, well, medicines are important, but we also need to attend to non-pharmacological treatment, and the clinical pathway considers healthy nutrition, keep a healthy body weight, avoid alcohol, vaping, no smoking or vaping. It incorporates new instruments with demonstrated evidence in reducing events like salts reduced in sodium and rich in potassium, and maintaining statins and aspirins as central or core interventions for patients who have a high cardiovascular risk, also like atonostatin, glyphosate, aspirin, etc. We know that these drugs also have an effect in delaying progression of terminal forms of these conditions. Finally, the clinical pathway monitoring, once the patient has been diagnosed, stratified, and treated, and reached his or her control objectives, we need to provide primary health care tools to trace frequent complications. That is for monitoring the kidney function, the glycemic metabolism, finding damage through electrocardiograms. If patients have a problem, they need complementary studies like echocardiograms. If there is heart insufficiency or arrhythmia in hypertensive patients, diabetic patients, overweight and aging people, we need to start anticoagulation and intervention that reduces up to 80% the stroke risk. So a number of complementary interventions, also vaccination against influenza, COVID, pneumococcus, so these people do not get complications and die if they are infected, something that COVID showed in a very dramatic fashion. On the other hand, we make visible what Professor Walton has studied, the fundamental role of the health
profesionales y no
team,
profesionales distintos del médico, pueden ser enfermeros, farmacéuticos,
professionals,
trabajadores comunitarios de la
nurses,
salud, deben
pharmaceutic
tener un rol central en el
personnel,
diagnóstico, tratamiento y
social
seguimiento
workers have
de estos
a
pacientes si
central
queremos
role
dar una
with
respuesta
patients
efectiva
at all
a una
stages if we
condición
want to give an effective
tan
response
prevalente.
to a
Para
very
finalizar,
prevalent
solamente decir
condition.
que HAR
To,
2.0 no
to
queda
end
en el
here, I'd
vacío,
like to
sino
say
que
that
forma
Hearts
parte
2.0
de una
is not in a
estrategia
void.
de
It is
mejora
part of
continua
a
de la calidad,
strategy
de una
that
estrategia
tries to improve
basada en la
quality
capacitación de
continuously.
los
It's
recursos
based on
humanos
training
y
human
basada en,
resources,
en el monitoreo continuo de indicadores de
on
proceso y
continuous
resultados que
monitoring
acompañen
of process
esta
and
mejora
result
continua de
indicators
calidad.
that
Muchas
underpin
gracias.
this continuous quality improvement. Thank you very much.
Andrés, excelente, excelente
Excellent,
presentación. Yo
Andres.
creo que es muy
Excellent
clara. Yo
presentation. I
creo que es muy
think it
clara.
was
Espero
very
que,
clear.
bueno, ahí están los aplausos para Andrés. Todas
You
las personas
have
que estamos en la
all
pantalla,
those
sí sabemos que
claps for
estamos despiertos,
Andres.
que nadie se está durmiendo. Aquí tenemos
Put them on the
2.600
screen to
participantes en la
know
sala.
if
Sí,
we are all
podemos
here. We
decir que
have
también estamos grabando
2,600
la sesión y la vamos a
participants
poner en
here.
nuestro
We are
canal de YouTube
recording the session
terminando la sesión. Así
and
que
we'll
si
put
ves el
it in
review lo
our
ves
YouTube
mejor
channel.
que no verlo en vivo.
It's better
¿Qué
to
es
see this live than
toque
not.
final a este
But I'd
asunto, ¿no?
like to
¿Verdad?
give
En
the
lo que
final
la gente
touch
hace este
to
experimento
this
que le voy a
issue.
preguntar ahora,
While you
entonces
do this
hablo con Paul.
experiment,
Pero
the
miren
question
ustedes
I'll ask
el QR
you,
que tenemos
but
ahí en la
look
pantalla.
the QR
Este
we
es el
have
paper que acaba de
in
publicar
on
ayer
the screen. This is a
American
paper
Journal of
that
Hypertension.
the
Entonces yo
American
quisiera que
Journal of
ustedes vayan allí,
Hypertension
tomen
published
su teléfono
yesterday.
un minuto,
Go there,
¿sí?
take your phone
Y
just a
vayan
minute
ahí y accedan al
and
paper. Ustedes quieren tener esto que
access the
Andrés ha dicho en
paper.
detalle. Ahí está el paper, el paper
Andres has
está
mentioned
publicado
this
por
in
American
detail.
Journal of
This paper
Hypertension.
has been
Salió
published
publicado
by the
ayer
American
la
Journal
versión, así que pueden
on
ir ahí. Esto no lo hemos
hypertension,
anunciado acá,
and
así que
this
vayan
is the
allí y lo
version. We
pueden
haven't
hacer
announced this,
directamente a
Dante.
la página
Go
web de
there,
American Journal of
and you will
Hypertension. Así
go
de
to the
paso,
American
por la
Journal
gente
for
conoce un
Hypertension.
poco más la revista, pero
In
vayan
this way, you'll get
directamente
to know
a
the
este
journal
paper.
too. Go directly to
Paul, te
this
quiero
paper, though.
preguntar en lo que la gente hace este
I'd
ejercicio y se
like
va
to ask
comunicando.
you, well,
Entonces le
do
vamos a
this
preguntar ahora si en
exercise.
efecto pudieron hacerlo o no
We're
pudieron
going
hacerlo,
to
pero
ask if
pueden ir
they were
trabajando.
able
Paul, ¿qué
to
le pareció a los editores
download
de
it.
American Journal of
What the
Hypertension cuando
AJH
sometimos esta
editors
actualización
think when we
a
submitted
revisión por
this
pares?
publication
¿Qué
to
opinión
a
te merece
peer
a ti como
review? What
editor y por qué
opinion
tú
did you
como
have as an
editor
editor,
editor en
and
jefe de
why,
American Journal
as
of Hypertension,
an
decidiste la publicación de
editor,
este artículo?
lead editor, decided to publish this article?
Well, thank you. Before I comment on the article, let me just congratulate Andres on a wonderful presentation. Absolutely fantastic. I was taking notes the whole time just because I think so many messages are crucial in terms of the hypertension treatment protocol, the treatment steps, complemented by non-pharmacologic approaches, including team-based care. So congratulations on a wonderful presentation, very important. In terms of the article, this is really important. The editors at the American Journal of Hypertension were very excited to receive this article because I think it emphasizes the points from the presentation today, what we need to do to make a difference. We don't, at the American Journal of Hypertension, we think it's important to publish science, but we also think it's important to focus on science that's going to impact patient care. And that is exactly what this article is focused on. It's focused on improving health and the pathway to do it. And that is why the editors were very excited to receive this article. Obviously went through rigorous peer review, and the reviewers, I can tell you personally, found it very important, and hopefully it will have a broad impact on the prevention and treatment of hypertension. And once again, not in isolation, but in the context of the patient holistically, the patient with multimorbidity, with whether it's cardiovascular, kidney, metabolic conditions. Once again, there's a pathway laid out in the article for reducing risk, extending lifespan, all the things that we want to see. So once again, congratulations on a wonderful article. and an outstanding presentation.
Muchas gracias, Paul. Muchas gracias, Paul. Muchas gracias, Andrés. Yo creo que estamos listos para
Thank you very
debatir
much,
un
Paul
poco con
and
nuestro
Andres. I
panel.
think we're a bit ready to debate
Pero
with our
antes de eso, yo
panel.
quería decir una cosa,
Before
quiero
that, I
que la
wanted
gente
to
no
say
nos
something,
perdone
Andres.
que no lo
People
hagamos,
don't
¿verdad?
forgive
La
us if
primera
we
cosa
don't
es,
do this. The first thing
digan si
is,
pudieron bajar el
say if
artículo,
you were
entrar al
able to
artículo del
download this
American
article,
Journal
the
of
AJH
Hypertension. Los que
article.
digan sí, pongan sí. Pongan sí en el, pongan
You
sí
can
los
put
que entraron y
yes,
bajaron el
yes.
artículo.
The people are putting yes
Digan
on the
sí los
chat.
que bajaron el artículo, los que pudieron hacerlo. Ahí
Those
tienen
who were
toda la
able to
evidencia
download
de
it,
dónde se
you have
basaron
the
esa, la
evidence
vía clínica de bajar. No
about
fue un ejercicio, no fue una
heart's clinical
fiesta, fue un
pathway. It
ejercicio
wasn't
riguroso
an
de evaluación de la
exercise
evidencia
or
del
a
más alto
party. It
nivel
was a
científico y
rigorous work
académico,
of the
con la
highest
idea de
scientific and academic
que
level.
cuando
The
ustedes
idea
regresen a
is
su
that when you
consultorio,
go
cuando
back to
regresen a
your
sus países,
um,
cuando hablen con sus autoridades, digan,
country
aquí está la evidencia. Y
offices
Andrés
and
decía que en los próximos días la
medicine
OMS va a
or
publicar el
doctors'
resumen
offices,
completo.
you have the
Tenemos el
evidence in
resumen
your
técnico
hands and will
completo de
publish
deliberación del panel,
the complete
completamente transparente con
technical
todas las
summary
votaciones, con todas
with
las,
the panel
con
deliberation,
todos
with
los
all the
requisitos
voting and all
de
the
calidad de cada una de las indicaciones.
quality requirements for
150
each
páginas va a tener
indication,
este es un
150
documento
pages.
obviamente que tiene otras
This is a
características, pero
document with
el
different
paper del
characteristics, of
American
course,
Journal
but
of
the
Hypertension,
HAH
quería volver a
paper
agradecer a Paul
is
a
great, and
diferencia
I
que tuvieron de
want
poder publicar
to
este paper y
thank
aceptarlo, yo creo que va a ser de
Paul
muchísima ayuda
for
para muchísima
accepting
gente
it
y
and
eso es
publishing
lo que
it.
estamos
It
esperando.
will
Así
be
que veo
very
que
helpful
bueno, hay
for
un
many
montón de gente
people.
que pudo bajar el
So
paper de
many
American Journal
people
of
were able
Hypertension.
to
Si
download
quieren
the
ahí ustedes
paper.
el ejercicio que estamos haciendo, Mariana nos está ayudando.
Mariana is
es nuestra
helping
super
us.
Mariana, que es la
Our
productora de aquí de
super
todo esto que está
Mariana,
saliendo acá
who
atrás
is the
y está el
producer
equipo de Heart
of
y están los
everything
intérpretes y
behind. We
está.
have
Bueno,
the
vamos a
Hearts
pasar
team,
entonces a nuestros
the
panelistas. ¿Qué les
interpreters,
parece,
and
Andrés? Muchísimas
everything.
gracias,
We'll go to our
felicitaciones
panelists.
por el
Andres,
resumen tan bueno que han hecho.
congratulations for this
Y
great
tenemos
summary.
cuatro panelistas
And we
estelares
have
aquí en este grupo,
4
¿no? Y yo
super
quiero
panelists here.
presentarlos en primer lugar.
I'd like to
Ricardo López Santi.
introduce
Ricardo López
Ricardo
Santi es
Lopez
un referente
Santi,
de la
who
cardiología en
is
esta
a
región, el
reference
presidente de la
in this
Sociedad
region. He
Interamericana de
chairs the
Cardiología.
Inter-American Society of
Representa
Cardiology.
la voz de los
He
cardiólogos.
represents the voice of
Es muy
cardiologists.
conocido también en los
He
medios,
is
así que es
very
muy
well
oído en
known
los medios
in the
también. Y que tenemos
social
orgullo de que
media
esté en los medios.
too.
Está Alejandro Ferreiro, que
Then
fue
we
el
have
pasado
Alejandro
presidente consejero de la
Ferreiro, who is
Sociedad
past president
Latinoamericana
of
de
the Latin
Cardiología,
American
hipertensión.
Society of
También todo un
Nephrology and
personaje de
Hypertension,
los nefrólogos de esta
also
región.
a character in the region.
Que viene colaborando con Hart
He
también hace
has been
mucho tiempo, Mark Jeffy hace
collaborating
mucho tiempo.
with Hearts and
Tenemos
Paho for a long
Mark
time
Jaffe,
now.
que es
We have
un
Mark
inspirador,
Jaffe,
es la figura
who
inspiradora de Hart.
is the
Si yo puedo decirlo
inspiring
así,
figure
Mark
of
Jaffe es
Hearts. Mark
un fuera de
Jaffe
serie, ¿sí?
is
Y
really
lo quiere mucho la gente de nosotros por
the
su claridad, por
greatest.
la manera en que presenta
People
las
love
cosas.
him
Él se
because of
presenta
the
como,
clarity with which he
como el
presents
jefe de
things.
los endocrinólogos,
He
pero
is
él es
like
un
the
poquito más que Mark
head
Jaffe.
of
Él es
all
el director de las
endocrinologists.
guías de práctica
He
clínica del cáncer,
directs
precisamente, y se inventó esta
um,
historia que nos tiene a todos trabajando durante años.
clinical
Así que bienvenido, Mark
practice
Jaffe. Y también
guidelines, and
Esteban
he's been
Londoño,
working with
que
us for
está
many
con
years. And
nosotros, es uno
Esteban
de nuestros
Londoño,
consultores en Heart en
who
América, un doctor
is
bien
one of the
conocido
Hearts
de
consultants
la
in the
salud pública y
Americas.
de la
He is
organización de los servicios de
knowledgeable
salud, del
on
enfoque del
public
sector público que
health
tiene
and
nuestro programa. Entonces,
public
voy a
health
empezar, así que
services.
presentado este
So
panel, o sea, un
once
super
I
panel
introduce
muy,
this super
empiezo por
panel,
Ricardo López
I
Santos.
start with
Ricardo,
Ricardo.
tú has sido clave en esta
Ricardo,
etapa,
you've
¿no?
been key
Sabemos que
at
la
this
hipertensión es
stage.
el factor
We
de
know that
principal factor de riesgo
hypertension is the
cardiovascular. No voy a
main
discutir ese tema porque lo hemos
risk
repetido hasta el cansancio. Claro, hay gente que
factor. I
todavía no lo
won't
entiende,
discuss this
lo hemos
because
repetido
we
hasta el
have
cansancio. Sin
repeated that
embargo,
so
nosotros
many
estamos viendo
times.
que
So
hay otros
we are saying, however,
tratamientos
that
como
there are
esta,
other
las terapias de
treatments like
cessación
statins and
tabaquista, la vacunación antiinfluenza,
stopping
la
smoking,
vacunación antineumococco.
vaccination
Cuando la gente la mira
for
bien, la vía clínica, la gente
influenza
dice, pero
and
¿eso qué hace aquí?
pneumococcal.
¿No? Y nosotros lo que creemos es
And
que forman parte de la prevención
we
cardiovascular,
think they are all
pero que
part of
continúan siendo
cardiovascular
subutilizadas.
prevention
¿Qué valor
issues,
tú
but
crees
they
que
are
entonces
still
HART 2.0 podría darle esto?
underused.
Ricardo,
What's the
bienvenido.
value of Hearts
Muchísimas gracias, Pedro.
2.0 in
Quiero
this?
aplaudir
Thank you
como
very much.
todos
I'd like
esta
to
iniciativa de
applaud, as
OPS y la
everyone, this
presentación de
PAHO
Andrés,
initiative
pero también
and
quiero aplaudir a
Andres's
la audiencia.
presentation, and also the audience, because the potential is there all over the continent, so that Hearts 2.0 can really be implemented. I think Andres's presentation has a couple of points, and that's the perspective of those who have been working on research. And all these aspects are very relevant. It seems obvious, like let's give high-dose statins to people who had a heart attack, or let's vaccinate against influenza and pneumococcal to those who have a high risk heart metabolic risk, and we should work on stopping tobacco. Empirically, that's been agreed among us all, and you don't hear any opposing voices. But from the point of view of practice, there's a big distance to this. This happened to us in our association. We checked immunizations, for example, and we saw that immunization rates against influenza and pneumococcal in cardiometabolic patients without COVID infection was only 40% in the region at the highest rate. That is 60% of patients were outside that vaccination. We see under-treated patients in our doctor's offices every day. That's why what we see, according to Andres's presentation, is this possibility of working in coordination with concrete targets that are very objective. And you don't need to read a 10-page paper to reach a conclusion. They express in a treatment algorithm which exposes our failures. If I have a patient with secondary prevention coming with low doses, and I find the chart that says I have to use 80 milligrams of atorvastatin, it's black and white, and it shows where we are failing. And I think that parts implementation can have a huge impact from the health point of view. We can start reducing that morbid mortality burden Andres showed us in the first image. These are all premature deaths, actually. We need to think about all those deaths, and behind them, there's a catastrophic situation in a family that loses part of their sustainment and development. From the point of view of the SIAC, and as an institution, we are totally aligned and will support implementation of this fantastic proposal. Excellent, Ricardo. Thank you very much. I think you brought a very important point. Support of cardiologists and societies so we can build together a collaboration space that in the end will impact people's health. I pass the floor to my co-moderator so he can address a question to one of these stars, Dr. Mark Jaffe. So Paul.
Okay, thank you. So Dr. Jaffrey, as an endocrinologist, you know better than anyone the relationship between hypertension and diabetes. However, oftentimes the medical and scientific communities remain anchored in a glucose-centric paradigm that results in hypertensives or antihypertensives and statins to be underutilized in people with type 2 diabetes. We know that there's benefit on reducing morbidity and mortality from these treatments. Can you reflect on this issue? And what is your opinion about the approach proposed by Hearts 2.0?
Professor Munter, that's a great question. And I just want to say how excited I am to be part of this, a small part of this 3,000 person team. It is fantastic, and it makes me very, very excited. Professor Munter, you bring up a good question that I think everybody knows, and you don't need a guideline for everybody on this call and even general practitioners from primary care to recognize people at high risk. Because whenever I give this talk or talk about this, when we say, you know, if someone's had a stroke or someone has heart disease or someone has a whole bunch of risk factors and their CV score is a jillion, or if they have diabetes, you know, here's news. They're at a high risk of a heart attack, stroke, or kidney failure. So every time, you know, I come as a professor to talk to a primary care clinic about this, I really feel that they should be lecturing me, because every time I do this, the primary care clinics say, of course, we get it. Those are our high risk patients. And I think of diabetes type 2 as a marker, as an indicator, a flag of people who are extremely high risk. And unfortunately, I think we've been practicing in silos in our individual domains for many years, we as a medical community. And this algorithm, it's wonderful. At the same time, it takes a complicated subject and it makes it simple. And I'm from California, and everybody's talking about artificial intelligence. Artificial intelligence this, artificial intelligence that. You're going to be replaced by a robot. And it reminds me of the work that I see being done in primary care clinics, where, let's be honest, a busy primary care doctor, nurse, pharmacist, health navigator has a whole bunch of patients, and you can use these wonderful tools. But identification of people at high risk is the key. Of course, we need to measure blood pressure, measure weight, measure glucose, establish who has diabetes, measure kidney function with tools. But that alone is insufficient, because I think it's really not a knowledge gap. It's a implementation gap. And I see this wonderful product produced by Andres and his team of very smart people. And they've taken a complicated topic and made it simple. And to me, that's where I see the future of successful implementation. Because as was been mentioned by several of the speakers, look, if you have a 100-page guideline or textbook, yes, that might be interesting, you know, reading if you had insomnia. But in terms of how it's going to really help patients, you know, I sort of wonder about that. And so I really think that identifying people at high risk and prioritizing them, providing them a little bit of extra care while not forgetting everybody else for whom we have to provide all these great interventions, I think that's the key. So I am super excited to see a simple, straightforward treatment plan on a single page. And one other thing I think we can't undervalue, and that is, we are all part of a big team. Today, I'm part of a 3,000 person team, but when we get off this call, I'll be part of a 300,000 or a 3 million person team trying to reduce the burden of cardiovascular disease on this planet. And by publishing and by presenting a simple, logical, stepwise protocol, think about how powerful that is. Think about how easy it will be to procure things because we've got a simple treatment algorithm. Think about how simple that will be to have all members of the team participate by using simple process steps. Think about how much easier it will be to monitor our progress because we've got a really core set of important benchmarks. And think about how helpful it will be for us to track our progress when we have several simple steps. So I am so proud of this group and all the great work that's been done, and I can't wait to hear what the rest of the presentations are and hear from the rest of the speakers. Thank you so much, Paul and Pedro.
Thank you, Mark. I think you raised a lot of great points about this HEARTS 2.0, not just being about a treatment plan, but an approach to identify gaps and challenges that people can face and how we can fill those, as well as monitoring progress. So I think it's has multiple purposes that you highlight very nicely. And I'll turn things back over to Pedro for the next question.
Bueno, muchísimas gracias. Yo cuando invité a Paul que me acompañara en este webinar le decía, te vas a
Thank you
divertir.
very
Y él
much. When I told Paul to come to this webinar, I told him, you're going to have fun. And he looked at me and he thought, what are you talking about? And I said, yes, yes, yes. You heard Mark Jaffe. Besides the fact that he's very wise, he's very entertaining. He says things that are very clear, things that people don't usually dare to say, because sometimes what we have done is a contest of complications. The more complicated it is, the happier we are. And the longer the document, the more erudite we are. But this is not how primary healthcare works. People don't have time. And when we present things like this, we are at another level. And Mark, you were saying, we were talking about teamwork. And then our professor, Tom Welker, was also talking about this. You know, yesterday was the Global Nurse Day, and I really want to applaud nurses because they are at the center of hearts in the Americas. They make things happen. And pharmaceuticals are also doing important progress because regulations in the Americas are being opened so that pharmaceuticals can participate in increasing the doses by following the HARTS protocol. In many countries, we have regulations so that we have manometers validated in health centers. Before HARTS in the Americas, we didn't have statin in primary healthcare. Today, statin are in all countries implementing HARTS, and that is a change in the mindsets. We have not changed the riches, we have changed the attitude of people. What we are doing is so rich, so important. So now I'm going to bring Alejandro Ferreiro. Alejandro, do you have any doubts about the fact that these diseases go together and that they are a cluster of conditions? Now we have Hearts 2.0, and that interaction that was, and we still have silos between kidneys, diabetes, pancreas, eyes, heart, head. But how does Heart 2.0, among its proposals, detects early on the risk markers that can let us know that we have these conditions? Because as you know, many people come in an advanced disease state. And how do the nephrologists see this, even with the incorporation of new therapeutics? Thank you very much, Pedro, Andres, and Paul, for inviting us. This reminds me about something that happened many years ago when we founded the American Society of Nephrology and Hypertension, because we had the idea that this had to be managed comprehensively because the patient is not one kidney, one heart, one liver. We have to manage them holistically. And the syndrome just names what we know, what we have known for a long time, as Andres was saying. Without any doubt, the use of strategies like the one we're talking about here takes to action, takes theory to action, and this is a great tool. If we think about kidney disease, and we estimate that in our territories around 60 million have kidney disease, but less than 10% know about it, it is important to establish strategies that will allow to diagnose the clinical situation, to establish the best options in this therapeutical guide, and to manage the patient holistically. Clearly, the early phase diagnosis must be done when the patient is going through the early stages of the disease. And it has to be done in primary healthcare services, identifying the risk factors that are also clearly identified in the guide, and these allow to have strategies that have perspective. They allow to have early diagnosis, like with osmotic creatinine. And also today we recommend the mandatory report of the urinomedular filtration to have a better management of these patients. It's even so mandatory that there are countries like Uruguay where we established this as mandatory less than a month ago. This is mandatory for labs. And then we have the urine test that has been available for more than 100 years, and it allows us to have better diagnosis. And so with this, we can identify risk patients and add this to the just cardiovascular risk or hypertension risk, and establish strategies that are cost effective in the management of this pathology and of all associated pathologies, especially cardiovascular morbidity. And I also want to highlight that the Hearts 2.0 guides includes other drugs that are not just linked to hypertension, because it has been shown that certain drugs have an impact, and this has been a motor for certain health institutions to cover patients that require it. So I think that these kinds of instruments are not only useful for doctors, nurses, or those who execute health policies. It can also be for people that are outside the health sector, and it's very useful to support those who do advocacy, because with these summaries of evidence, we can request to authorities to include statins or other drugs in clinical practice. But it's not only that. Today, Andres was saying what happens when it's difficult to contain hypertension. Then we have other treatments like corticoids for the treatment of resistant hypertension. So in that single page, there's a lot of information that allows us to manage more than the median of the patients with cardio-metabolic syndrome. And about the question of doing this in the first level of care, yes, of course, because that's where the patients are. And specialists have to work in counter reference, because there might be individuals that have different responses that do not correspond to the median response. And that's where we have the role of specialists. But these kinds of recommendations are necessary. First, because specialists cannot manage the whole of patients that have these pathologies. We have to work with primary healthcare doctors, doctors and all the people that work in these teams. But let me remind you, and this is a specialist mea culpa, we have to also ensure the training of these specialists can have continuous training, so that because these instruments also bring a lot. I just sent the publication that you shared in the video to all of the nephrologists in Uruguay so that they can read this, because it is necessary to have this information, because we also have black holes in terms of knowledge for those who work in specialties. So I really want to congratulate this initiative. I accompany it, I defend it, and I hope that it will continue evolving, because then we will have version 3.0 in the future, because medical evidence evolves very quickly, and the use of sanitary strategies is also something that evolves very quickly. So in some time, we will probably be talking again about another initiative. But I really defend
y
this,
creo que los
the
nefrólogos
teeth and claws,
tienen que
and I
estar
think that
alineados a esta
nephrologists have to
estrategia
be
que
aligned with
sabemos
these
que salvan
strategies
vidas, que mejoran la
because we
calidad de
know that
vida,
they
que
save lives, we know that
prolongan la
they
vida de los
improve the
individuos
quality of
y
life, they
disminuye el
make
impacto
lives
en
longer
otras
and better,
patologías que
and
están
they
asociadas,
also
pensando que el
decrease the
individuo
impact in other
es un
associated
ser
pathologies
social y en el
because the
cual los
individual is a
médicos y
social
enfermeros
being,
conocen
and
perfectamente en qué
primary
ámbito
healthcare
se dan los
doctors
tratamientos, en qué
know
ámbito se mueven los
perfectly
pacientes, mucho más que
where
los
the
médicos especialistas.
patients
Muchísimas
move
gracias, Alejandro.
and how they
Brillante,
follow the
brillante
treatment or
como
not,
siempre
and
lo
they know them
cuenta.
much better than the
Este es un
specialists.
panel que es muy complicado
Very
porque tiene gente que
eloquent
habla
as
muy bien,
always,
que sabe
Alejandro.
mucho,
It's
y
a
el tiempo
very
es
complex
limitado,
panel
¿no?
because
Como el programa que tenemos, así que los
people in
invito
this
a...
panel
Tenemos
know a
hoy
lot
700 personas en
and
la
they have
sala
very few
escuchando
time
esto,
to talk.
¿verdad? Además de la
We have
información. Pero qué bueno saber que los nefrólogos,
2,700
pero
people in
voy a
the
dar un
room.
adelanto, Ricardo.
It's
Esta es
good
la
to know
segunda
about the
parte. Yo voy a hacer la
nephrologists.
pregunta a Andrés ahora, pero
I'm
voy a hacer
going
un
to ask
adelanto.
Andres
En
a
el Congreso
question.
Interamericano de
In
Cardiología
the
en la ciudad de Panamá en
Inter-American
julio,
Cardiology
la CIA, la Sociedad
Congress in
Interamericana de
Panama and
Cardiología,
Julia,
está
the CIA
auspiciando un evento multisociedad
was
en apoyo a Heart
having a
2.0, para poner en ejemplo,
multi-society
y están los
event in
nefrólogos
support of
invitados.
Hearts
Esto
2.0,
es
and the
una
nephrologists
iniciativa
are
que está
invited there.
liderando
This is an
Ricardo,
initiative led by
y nos han dado un
Ricardo,
espacio en el Congreso Interamericano de
and they have
Cardiología para poder
provided
transmitir esto.
a
Andrés, voy
space
contigo.
in the
Fíjate tú, el
CIA
tratamiento
Congress.
antihipertensivo, tal como lo vemos
Hypertensive
ahora, uno de los
treatment,
grandes
as we
problemas
see it
que
today,
tiene es qué tipo de
one of its
medicamento le damos a la
greatest
gente,
problems
¿verdad?
is what
Y
kind
aunque
of
la
medicine
primera
we
vía
of
clínica
drug we
de
give
HART
to
ya
the people.
hablaba de
And
combinaciones de
the first
oxígeno, tú
clinical
sabes que este ha sido
pathway of hearts talks
una
about this,
batalla
but
que no
you
ha
know that it
sido
has been a
fácil
battle and
por
has
muchas
not
razones.
been
Entonces,
easy for
si bien
many
ese
reasons.
tratamiento antihipertensivo
Although this
se han optimizado las combinaciones
antihypertensive
triples
treatment has
o
been
doble,
used with
incluso con
triple or
combinaciones
double
triples, y
combinations,
con el inicio de las espironolactona en pacientes
and with
hipertensos,
the
tú
beginning of
pudieras
spironolactones
ampliar
in
este punto a
hypertensive
dónde
patients,
estamos y qué cosas
maybe
deberíamos
you
hacer.
could talk about this point, where we're
Adelante.
at and what we should do.
Gracias, Pedro. Sí, si
Thank
nosotros
you,
queremos
Pedro.
incrementar el control de la
If we
hipertensión
want to
arterial, no
increase the
solamente tenemos
control
que
of arterial
cerrar la brecha
hypertension,
diagnóstica, es decir,
we must
ir a
first
encontrar
of
ese
all
30% de los
close
hipertensos
the
que no saben que lo son, sino además
diagnose breach,
tratarlos.
find
Y
those
ese no es uno
hypertensive
de los
people that
principales
don't know that
problemas.
they
La
are
región de las
hypertensive,
Américas
and then treat them. But
está
that's not the only
en el
problem. The
primer
region of the
lugar a nivel
Americas
mundial en acceso al
has a
tratamiento,
first place in
pero
the world in terms of
empezamos a
access to
fallar en la
treatment,
calidad de ese
but
tratamiento,
we
porque tenemos
fail
más
in
de
the
dos terceras
quality of
partes tratados
treatment
con
because we
monoterapia.
have
¿Y sabes cuál es la media
two-thirds
reducción de la
treated with
presión arterial
monotherapy.
sistólica
And
con
you
un
know what
solo
is the
fármaco
median
a
of
dosis estándar? 7
reduction with a
milímetros de mercurio.
single
Esto
drug?
es algo que ya
7 millimeters
demostró
of
Wall y
mercury. This
Lowe
is
hace más de
something
20
showed by
años.
Wall and Mercury over 20
Entonces,
years ago.
si nosotros estamos
And
diciendo
so if we are
que hoy
saying
en día
that
todavía
today
estamos empezando tratamiento
we
de
are
hipertensión en la mayoría de
starting
los
to treat
pacientes con
hypertension
más de
in most of
140 de
patients,
sistólica
and
y
with
le vamos a poner
MODA
monoterapia, pues no vamos a
140 of
tener prácticamente
systolic
efecto.
and
Quizás
monotherapy, well, we won't
adelantando
have
a lo
any
que
effect.
decía Alejandro Ferreiro del
And to
futuro
talk
de
about
Heart
what
2.0 y
Alejandro
Heart
Ferreiro was
3.0,
saying about
hoy
the
en día tenemos
future of
evidencia
Hearts
de
2.0 and
que
3.0,
ser
today we
más
have evidence
intensivos en la reducción de la
that
presión
being
arterial
more intensive in
sigue
the reduction of
mejorando
blood pressure
la prevención de eventos
continues
cardiovasculares y es
improving
bien
the
tolerada por
prevention of
parte de los pacientes.
cardiovascular
Entonces,
events, and it is well
si
tolerated by the
estamos
patients.
cerca de
And so
empezar
we
a
are
tratar al paciente más
close
precozmente y
to
de
start
perseguir
treating
objetivos más
patients more
estrictos de
precociously
control,
and
¿cómo
following
podemos hacer eso?
more strict
Dando
control
enalapril
objectives.
5 miligramos una
How
vez al
will
día,
we
por
do that
ejemplo, que
with
es el tratamiento más
5 milligrams of
frecuentemente
April
prescrito con un
daily, which is the
fármaco que
most
no cubre las
frequent treatment
24 horas
with
de
a drug that
tratamiento,
doesn't
que
cover the
necesita
24 hours
para
of treatment,
cumplir su efecto al
that
menos 2 dosis
needs
diarias
at
y que lo
least
estamos
2
dando
doses
sin
daily to
acompañamiento
comply with its effect,
de
and
otro
we're
agente.
giving
Por
it
eso es
without another agent.
tremendamente importante
So it's
que
very
empecemos a
important
pensar
to start thinking
cada vez que tenemos un paciente
every time that
delante,
we have a
¿por qué
patient in
este
front of us,
paciente no
why
debería llevar
should this
tratamiento
patient,
combinado?
why
En vez
shouldn't we
de
give this
en qué
patient combined
pacientes voy a
treatment?
poner terapia
Instead of
combinada y en qué
thinking,
pacientes no voy a
what
poner terapia
patients
combinada.
should I
Porque la
give
terapia
combined
combinada
therapy? I
tiene
should be
que
thinking
convertirse de una vez por
uh,
todas en un estándar de tratamiento.
the combined therapy has to become
Muy bien,
standard of treatment very well, Andres. I think that is a very important subject. I want to ask you a question. Out of the 30 countries that are actively implementing the HEARTS pathway, how many combine fixed doses in the first step? 27.
27 combinaciones de dos, pero es una sola,
27
en una sola
combinations
cápsula.
of two, but in a single
No, son
pill?
alrededor de 7 u
No,
8.
It's around 7 or 8. Okay. So we have 27 countries that are combining two drugs, but only 7 or 8 countries have incorporated the fixed doses in one single pill. And this is an essential measure if we want to get to the control levels that we are aspiring to. We know that this is not so easy. There is something that we have talked about here. It's the implementation of a program such as this. This is why I'm asking Esteban, which is another of our panelists. He is the fourth panelist of this group. How do we position the HEARTS 2.0 clinical pathway in the continuous improvement strategy? Hello to everyone. It's a pleasure to be here. I would like to bring a more public health vision. I'm going to refer to how the HEARTS 2.0 clinical pathway has two contributions. First of all, it improves quality of primary healthcare, and then science of implementation. So to talk about the first one, HEARTS is designed like as a program to improve quality in primary healthcare. And 2.0 boosts this because it contributes specifically. HEARTS 2.0, I consider it as the main operational cement developed until now to implement a care that has these components. An integrated care approach, effective and centered on people for non-communicable diseases in primary healthcare services. So beyond clinical pathways, I would like to understand the HEARTS 2.0 clinical pathway as a comprehensive care pathway. This is something that was said by Alejandro in his intervention. So HEARTS 2.0 represents a natural evolution of hearts, going from isolated risk factors to an integrated model of care that is cardio, kidney, and metabolic throughout the life cycle without any interruptions to its continuity. And this is not done overnight. We are responding to a need expressed in the territories and the countries committed with hearts. First of all, we are responding to demand from the first level of care, nurses and doctors that see multimorbidity patients with many risk factors. It also responds to health systems that are under pressure, that face financial pressures, organizational pressures, and management pressures. And so it needs more efficient and sustainable models. But I would like to say something that Alejandro also mentioned, the response to patients, people that don't want to be treated as fragments of different diseases. They have to go to different services that are disconnected. They want to have a real integration of care. And so we promote for primary healthcare services to become the great coordinators of clinical care, helping people to navigate the system in an integrated manner. In this context, HEARTS 2.0 strengthens the clinical articulation and the management articulation with the integrated health networks, and all countries in the Americas have been boosting this through a renewed operational framework that is oriented towards change management. This is the first thing. And then we have the science of implementation. In the introduction done by Ricardo, I think that this was very interesting. There's a real gap because of this scientific knowledge is not translated into practice. And in implementation sciences, it's very clear. 17 years is a time scientific innovation takes to get to routine practice. It's decades. It's unacceptable. And I think that HEARTS 2.0 has a strategic value there because it synthesizes the best available evidence to approach multimorbidity in a very practical and actionable way that can be adapted to the context of primary healthcare. So as you were able to see in what Andres presented, we have a nucleus of essential interventions that are not only clinical, they are clinical, they are organizational, but it also allows to have flexibility according to the realities of each health system. And so these opportunities start having a great value because we're saying it's not rigid. They can be adapted to the reality of each country. So to close, the Hearts 2.0 clinical pathway is much more than a clinical pathway. It's an instrument to transform care models, and it allows to take integrated care to the primary health level. So I'm sure that it is here to be implemented, and I congratulate everyone that's working on this. Excellent, Esteban. I would like to know if our public that is very large agrees with that, and I would like them to react in the chat. Do you think that what Esteban said is the road we should follow?
Entonces, muy bien, voy a darle la palabra a Ricardo.
So I'm going to give the floor to Ricardo, and we're going to go to the last segment, and we have to move quickly because time is very short. Ricardo is a president of the Cardiologist Association. How does the Cardiologist Association in the Americas position regarding these ideas? When Mariana shared the map, I was looking at the 27 member societies that are installed in the territories in those places. Today, the role of the Inter-American Society is to articulate these 2,700 players that feel identified with these national societies to knock the door of decision makers, because definitely the decision makers also want the well-being of their people. The fear that they have is not being able to execute due to economic conditions, due to other factors, being able to implement the program, and that certainty, that security belongs to scientific institutions. And I see that cardiologists, nephrologists, endocrinologists, the medical community in general, has a very well-defined role, the role to do advocacy. As Alejandro was saying, I think that this is our responsibility and we have to take it forward. A very concrete example, in Bahia next week, we will be together. We will have SIAC reference, including Dr. Ana Minera, that is leaving the presidency right now in my hand. We will also have the Brazilian Society of Cardiology, whose president is Sergio Montenegro, and he is supporting this firmly. We have a local cardiologist from Bahia, and we have the PAHO representative in this case. And together, we are going to try to knock on the doors of Bahia decision makers in the health secretariat. And so I believe that this shows the role that we attribute to scientific societies. Brilliant, Ricardo. The Brazilians have a chat for that meeting and for Hearts in Brazil. And they were celebrating the fact that you were mentioning the Bahia meeting. Yes, we're going to be in Bahia. Bahia is going to be available. We want to launch Hearts in Bahia, and this has to be an enormous movement that we work on in the continent. And now I give the floor, I give the next question to Paul so that he And Mark Jaffe can respond to the next question. Paul,
Thank you.
go ahead.
Thank you, Pedro. Mark, once again, Kaiser Permanente, the model they have has been very successful in controlling blood pressure, controlling hypertension. In fact, it seems like Hearts has been inspired by it. Since you've been leading the Kaiser Permanente model, what have been the keys to the success that you've seen, and what can countries implementing Hearts learn from it?
Thanks, Paul. And yeah, so I work at Kaiser Permanente, been there over 30 years, and I see so many similarities to our integrated healthcare system as I do to many of the places throughout the world and in Central and Latin America, in the PAHO region. And the key learnings, I think, is that you need to involve everybody. And let's be honest. The cardiologists, nephrologists, and endocrinologists, like myself, we may be the experts in what to do, but realistically, the primary care teams, nurses, pharmacists, medical assistants, they're the experts in how to do it. And I think we need to be humble and we need to give them the tools so that they can flourish. And I think it really is about acknowledging who the experts in the room are. And I might be an expert on what drug to use for diabetes and how to adjust this or that, but I really need to defer to the expertise of those primary care clinics. And I think that for me, it's really an exercise in change management, in acknowledging where most of the patients go, because in my organization, and I think in most organizations around the planet, the majority of patients are going to be getting their care in the primary care center, not at the specialist. So what we need is the specialists to be thought leaders and to be facilitators and to sponsor things, and as been mentioned before, to help the primary care teams be successful. And that has been terrific. And when I mentioned before about part of the team, I view the team as everybody, including your sponsors, because your sponsors have to be on board with procuring affordable, safe, single pill combination medications. Your specialists have to be on board with agreeing to select just a few drugs which can be on your formulary to make things easier. And your primary care teams can really help up with the logistics, the assessment and monitoring. And for me, as a specialist, that's what I've really learned from implementing in very large healthcare systems. And I know that the specialists can learn a lot from the primary care centers. It's almost like I should be stepping down from this position on this panel and having one of the thousands of primary care doctors take my place and let us know what it's really like in primary care. So that's how we do it. And that would be my one parting suggestion to people who are trying to implement this across a big program.
Thank you. I think it's really informative given the sustainability of the program over decades now and the impact it's had, what we can learn from it. So thank you very much, and I'll pass things back to Pedro.
Muchas gracias, Paul, y muchas gracias, Mark, por esas palabras. Yo los invito
Thank you very much, Paul and Mark, for your words. I invite the panelists to check out the chat to see how the people are reacting, their questions. If you want to answer their questions, it'll be okay. This is such a big webinar that we won't be able to answer everything. Lots of participation and enthusiasm. We have 2,700 people in the room without leaving. To close this panel, I go with Alejandro. Same question as the one I asked Ricardo. We have the ILAM, the nephrology, Latin American Nephrology Association ready to support Hearts 2.0? I think they are, and if they aren't, they should be. That's what we think about this. Undoubtedly, well, there are countries where there is just one nephrologist per 100,000 inhabitants or 1 million inhabitants, and it's difficult to manage kidney diseases, a problem that everybody knows about. In some clusters, it has very high frequency that is managed by informal players, as it happens with chronic diseases in Latin America. We need to work with the primary health care level. Undoubtedly, that is the level that should manage the majority of patients. In that regard, our society, in particularly, and the international one, have developed for some years now a number of strategies to work jointly with the ministries of health, particularly ministry associations, Orascon, Comica, PAHO. I mean, strategies to foster management of kidney disease, both acute and chronic. Both occur at community level, and they are not managed by nephrologists. And they both have impact on diseases and evolution of cardiovascular problems. The heart's pathway is a toolbox, and we have a similar one for kidney with lots of support to the primary care level. Nephrologists have to participate as a counter reference. Doctors in the primary health care level facing a case that is out of the first stages of kidney diseases needs to use therapeutical strategies together with the specialist physician. And this has also been mentioned in the clinical pathway, the use of new technologies, particularly telehealth, telenephrology, for example. There are very good experiences there. The Chilean experience is one of its kind. The nephrologist participates with the primary health care level and supports the primary health care level for managing the clinical case and also working with patients in the outpatient environment. We're working on that. We need to step out from hospital nephrology and dialysis to support the main players, primary health care levels, nurses, players in the health area that will manage these pathologies and should do so appropriately. And that's what we have to promote. Very, very good, Alejandro. Thank you very much. Production is passing lots of messages to me. I have a private chat and a public chat. And they're saying, we have no time, Pedro. What will we do? How can we stop this conversation? Our panelists have been brilliant. I have a trick for you here. Take your phone. This is the heart's clinical pathway. This is the Lancet Primary Care publication. It was published on Saturday. So download this comment concerning the implications of the heart's clinical pathway. Hearts 2.0, I mean. Okay, download it. It's also a great effort. We wanted to have it published before this day, before this webinar. I'm asking Paul Muntner, who's my co-moderator, to say a few words to close this panel. Paul, you have the floor.
Thank you. And I'd like to thank Ricardo, Alejandro, Mark, and Esteban for wonderful comments. I think that just hearing some of the things they said about the really the importance to recognize people at high risk, how we need to move away from practicing in silos, the use of team-based care. In addition, really being humble about things and recognizing who the experts are, understanding your expertise, but really the team-based care model where you can leverage the expertise of everyone. And then finally, the last comment really resonated with me. Alejandro talking not just about nephrology, but talking about telehealth, yet another tool that we can use in implementation. And so there's so many great comments that we can use to overcome these treatment gaps, increase appropriate medication use for hypertension, but also cardiovascular risk reduction. And that I just want to congratulate everyone on such a great conversation and pass things back over to Pedro.
Muy bien, muchas gracias, Paul. Felicitaciones. Entonces, yo le pido
Thank
a
you very
todos un
much, Paul.
aplauso
Congrats.
masivo.
Big round of
Le
applause
pido un aplauso masivo para todos nuestros panelistas que vayan
for
ahí, que
all
se
of our
reflejen, que
panelists.
tiren la foto de la
Go, go,
aceptación
go.
que ha tenido sus
Show your
presentaciones.
acceptance
Y qué bueno tenerlos a ustedes aquí
for
que
these
sean claros en que
presentations.
este
It's
es un
great to have you
momento
all here
esencial donde
in
necesitamos la
this
participación de
essential
todos.
moment
Ahora,
where
fueron
we
un
need
buen ejemplo de
everybody's
eso, cómo un
participation.
sistema lo integra y cómo
A
eso
good
puede
example
llevar a
of this and how a
Cardio-Kidney-Metabolic.
system integrates
Vamos a ver
this
lo que
and
hacen
how we
en
go
este
to
video,
next level.
Mariana,
We'll
donde
see
vamos a
a
poner
video.
lo que está haciendo
Mariana will
República Dominicana con la
put
implementación de
on
HART.
this
¿Qué te parece,
video
Mariana?
and
Tú que eres
what
la
Dominican
productora.
Republic
¿Estoy
is
bien con eso?
doing in implementing hearts.
Adelante, habíamos
Bueno,
cambiado un poco el orden, pero si
We had
Libardo nos puede
changed
hacer el
the
favor,
order, but if
presentamos al
Libardo
líder
can
de líderes.
show the video,
ok, muy bien.
we'll
Yo pensé que tengo aquí mi guión
introduce a
que dice
leader of
que iba a
leaders.
eso. Ok, adelante.
Mira,
Okay,
oye,
go
si
ahead.
vives en Ciudad Juan Bosch, esto es para ti.
Hey, this is for you.
Hoy quiero hablar de algo que
I want
muchas
to
veces
talk about
pasa desapercibido.
something,
La presión alta y la diabetes.
things
Son
that
enfermedades
are
silenciosas,
not noticed.
pero
High
casi
blood
siempre
pressure and
provocan
diabetes are
complicaciones
silent
graves
diseases,
y no
but
se detectan
it
o
produce
controlan. Por
serious
eso,
complications if they
siempre
aren't
continuamos
detected and
potenciando
controlled
la estrategia
in
HART,
time, on time.
acercando
That's
la
why we
prevención y el
strengthen
seguimiento a
the
la
heart
gente
strategy
desde los centros
and
de
we
salud.
approach
HARTS se desarrolla en
follow-up
los centros de atención
from
de primer nivel,
primary health
donde las
care
personas
levels.
pueden acceder de
There,
manera
people
directa
can have
a servicios de
direct
prevención,
access to prevention
diagnóstico y
services
control de
and
estas
also
condiciones.
diagnosis and control of
Allí
these
puedes medirte
conditions.
la presión,
There, you
controlar tu
can
azúcar,
measure your
recibir orientación
pressure,
médica
control
y dar
your
seguimiento
blood
continuo a
sugar,
tus tratamientos.
get
Además,
medical health care,
si lo
and have
necesitas,
continuous
si tu médico
treatment.
te lo
Also,
indica,
if you need it and your
recibirás
doctor
los
so
medicamentos de
says,
manera
you will
gratuita,
get your
medicamentos de última
medicine
generación
free,
totalmente gratis como
free.
parte de tu atención,
Less cutting
garantizando
edge
continuidad
medication.
en
That's
cuidado
part
de
of
tu
the
salud.
attention,
Y te tengo
guarantees
otra noticia.
continuity
Desde
and
ya,
care for your health.
esta
Another
estrategia
piece of
también
news
está
is that this
disponible en
strategy
Ciudad Juan Bosch.
is
Si
available
viviste en
in
esta
Juan Bosch
comunidad, te
City.
invito a
If you live
acercarte a
in
tu
this
centro de primer nivel
community,
de
go
atención
to your primary
y
health care
aprovechar
level
estos
and
servicios.
take advantage of
Cuidarte
these
hoy
services.
es una
Take care
decisión que
today.
impacta tu
That's a
presente
decision
y
that
tu
will
futuro.
impact your present and your future.
Bueno, muchísimas gracias,
Very
República
well. Thank you
Dominicana,
very
por
much,
esta
Dominican
cortesía.
Republic, for this
Yo, alguna gente me
message.
pregunta cómo ustedes seleccionan esto.
Some
Digo,
people
todos los que
ask me,
ustedes
how
tengan
do you
ejemplos gráficos los
select
pueden mandar. Si tienen
um,
un video de
videos?
este
If you
tipo,
have
con
any
el
graphic
ministro de Salud
examples,
de
if you
su
have
país
videos, you can
promoviendo la
send them.
implementación
If
de
there's a
HART, pues
Ministry of Health of
encantado de
your country
compartirlo en esta
promoting hearts,
comunidad.
we'll be
De
so
hecho,
glad to
Ricardo,
share
vamos a
that
tener
in
al
our
ministro de
community.
Salud de
Ricardo will
República
have the Minister of
Dominicana en
Health
nuestra
of
reunión de
Dominican
HART,
Republic in our hearts
en nuestro
meeting
Congreso Interamericano de
in the
Cardiología en Panamá.
Inter-American
Así que
Congress of
lo que más le puedo decir es
Cardiology in
invito a los
Panama.
países
So
hagan
I
trabajos como este
invite
y
all the
esta va a ser una
countries to do
plataforma
work like this,
tremenda
and this will
de
be a
reconocimiento. Felicitaciones a los
tremendous
panelistas y
platform.
vamos al próximo
So
bloque
congratulations
y nos
to our
vamos a enterar
panelists, and we'll
entonces
go to the last
cómo
block,
el
and we'll get
centro
to know how
Vireme, que es la biblioteca
the Viremes
especializada en la
Center, the
búsqueda de
specialized
información en salud de
library
nuestra región
on
y una de sus
healthcare
especialistas que es
searches in our
Rosemeire
region,
Rocha de
and
Brasil, a
one of
propósito,
our
nos
specialists,
presenta unos
Rosemeire
recursos
Rocha
para
from
toda la gente
Brazil,
que están aquí
will
escuchando
present a
este
resource
webinar en el
for
día de hoy.
all of
Adelante.
you who have been listening to this webinar. Go ahead.
Hola, buenos días, buenas tardes a todos. Me gustaría mucho agradecer, doctor
Good morning, good afternoon to everyone. I'd like to thank Dr. Ordóñez and Mantner for the opportunity of presenting this, which is the showcase of hearts in the Americas. Mariana, can you pass the slide, please? Next one, please. The next one, please. Thank you. So this knowledge showcase has been developed by BIREME. It organizes and gives visibility to scientific knowledge that is available on health priority issues. In the case of the Hearts 2.0, it gathers technical and strategic contents that support research and decision-making in primary health care. This was built through collaboration between BIREME and the Hearts Initiative in the Americas at the Unit of Non-Communicable and Mental Health Diseases of PAHO WHO. Its main purpose is to organize and provide visibility to scientific and technical production generated by the Hearts Initiative in the Americas in an accessible and dynamic way. It gives access to documents and resources related to different initiative work lines. It strengthens dissemination and use of knowledge to support implementation in the region.
Deja ver si yo puedo pasar. No puedo, Mariana. Ah, sí, ahora sí. Hearts en las Américas ha generado una gran cantidad de
has generated a large amount of technical and scientific resources in the Americas to facilitate access to this content. This platform organizes the information in three large components. First of all, direct access to strategic resources, guides, courses, and clinical tools. The second one is thematic and structured navigation that is structured according to the initiative's work lines, providing access to documents and resources. Thirdly, and the most important, we have an integrated repository of knowledge that gathers and organizes scientific and technical production generated by Hearts. We are still compiling it, and we are updating it all the time.
El próximo.
Next one.
Gracias. Es importante destacar que la
important to highlight that the Hearts collection in the Americas is a live repository that is continuously updated. This goes hand in hand with Hearts 2.0 and incorporates new documents, evidence, and strategic resources that are generated in the context of Hearts in the Americas. We invite you to download this platform and use it as a support tool for your clinical practice, investigation, implementation of Hearts in your own work context. You can have access through the URL or at the Hearts website or through the QR code we are showing on the screen. Thank you very much. I think we have a quick video now. Thank you very much for your attention. Go get this platform. Thanks.
Muy bien, Rosemary, muy bien.
Great, Rosemary. We're very happy with this resource. And now all of our Hearts community is more than 50 million people covered by the program and 12,000 healthcare centers, 30 countries implementing. And now we have this platform. Let's have the video now.
Uy, ¿qué nos pasó?
Are we there?
Sí. ¿Nos pasó algo?
Did
Bueno,
something happen?
Esto suele pasar cuando estamos en vivo. Sí.
Well,
Parece que tenemos
this
algún fallo
happens when
técnico,
we
como
go
dicen en la
live.
televisión. No
as they say on TV, well, we have a technical glitch. We don't know what it is, but we do have one apparently. And you probably solve the problem at production. But I give way to the last segment. Rosemary, thank you very much for your work and how you have collaborated with us. And now I pass the floor to the last presentation, Professor Paul Welton, a very high level professional, an indefatigable fighter, a professor, an inspirer of many generations, who has taken some time to share with us their knowledge and advice.
Thank you, Pedro. It's a wonderful pleasure to be with you and our almost 3,000 participants today. Could I have my first slide, please? So it is a great pleasure to be here as we get close to celebrating World Hypertension Day, something that the World Hypertension League has been doing since 2005. And we are, as Gianfranco mentioned, so honored and privileged to have a strong relationship with PAHO. So I'm going to talk a little bit about blood pressure today, and I want to focus a little bit on risk first. So in this left-hand panel here is mostly what we look at. There's an exquisite relationship between average level of blood pressure, which is what hearts measures. It's the right measure for blood pressure, accurate measure of average level of blood pressure. It's exquisitely related to many outcomes. We typically think of stroke and ischemic heart disease, but it's many other outcomes: heart failure, chronic kidney disease, kidney failure, atrial fibrillation, hypertensive cardiomyopathy, cognitive impairment, dementia, valvular disease. These are all related to blood pressure, and many of them are long-term consequences. And we typically think of systolic as being the better predictor, and in the traditional cohorts, we look at systolic from about 110 to 180. But we know now in this, I'm showing you here in this top right-hand panel, that the risk relationship starts at a much lower level of blood pressure. And this is a study that looked at people who are at very low risk for cardiovascular disease and had a systolic blood pressure at the start between 90 and 129 millimeters of mercury. And that baseline blood pressure was again exquisitely related not only to predicting progression to higher levels of blood pressure, but other cardiovascular risk factors, intermediate outcomes like coronary artery calcium, both single vessel and complex disease, and as I'm showing in this slide, atherosclerotic events. So we have this relationship that goes certainly from 90 to over 180. And if you think about the isolated societies that do not see blood pressure increase with aging, and we have about 30 or more of them, their average blood pressure is typically, the systolic is typically about 90 to 100 millimeters of mercury. So we're designed as a body to really have much lower levels of blood pressure than we have in most of our societies. We live in societies where our foods are not very healthy. We don't exercise enough. We drink too much alcohol, and we end up with pressures that on average are much higher than they should be in terms of risk. And again, I just want to point out that blood pressure is, as others have stated, the most important reversible risk factor for predicting cardiovascular events, mortality, disability. And again, I think hearts made the right decision to start with high blood pressure and tackle that first, and now expand it to get at some of the other very important risk predictors for both death and disability. And I'll come back to that in a moment. So next slide, please. Yesterday, our group has been monitoring global burden due to high blood pressure, prevalence, awareness, treatment, and control rates. We've done that several times, and yesterday we had a lead article in the Journal of the American College of Cardiology. It's a hypertension-themed issue, and we updated our results to 2020. And looking at 140/90, a very high cut point for defining high blood pressure, it's extraordinarily common. It has gone down a little bit in the high-income countries, but it's going up progressively in middle and low-income countries where most people live. And worldwide, for 140/90, about 33%. That's 1 in every 3 adults over the age of 20. If you were to use the cut points that we use in the United States, 130/80, it's actually close to half of all adults in the universe have high blood pressure. So it's exceedingly common. And if you translate that into millions affected, our estimates as of 2020 were not 1.4 billion, as Gianfranco mentioned, but actually 1.7 billion. That's 1.7 billion above 140/90, very high levels of blood pressure. Again, if you were to look at 130/80, that's about 2.5 billion adults. So it's unbelievably common. Next slide. I want to just point out that we've looked at regions, and if you look at Latin America and the Caribbean, sadly, Latin America and the Caribbean has about the highest prevalence of hypertension anywhere in the world. It rivals sub-Saharan Africa. Those are the two regions with the very highest level. Look at this, 140/90, almost 40% of all adults over the age of 20. And that means about 150 million individuals. So our work is cut out for us. We know the risk. Next slide. And we know what to do. I won't dwell on it, but every guideline has more or less the same advice. At lower levels of blood pressure, try to encourage people to live a healthy lifestyle. At very high levels of blood pressure, add in any hypertensive drug therapy. Somewhere in between, we say in the US, we call it stage 1 hypertension, 130/139. Others will use different terminology, but typically at 130/139, we want to know, does somebody have high underlying risk? Again, something that Hearts looks at very carefully. And if they have clinical events, obviously they're at high risk. And as Mark Jaffe has mentioned, if they have that level of blood pressure in combination with older age or diabetes or chronic kidney disease, they're almost certainly going to be at high risk. And I want to mention that in diabetes, those with diabetes and stage 1 hypertension develop high risk about 12 years earlier than everybody else. And for those with chronic kidney disease, they develop high risk about 7 years earlier. So they're not only at high risk, but they're getting it earlier in life, and that multiplies the risk. And then we can use risk predictors. They're very useful for people who we're uncertain about, but I also want to just underscore that they tend to miss risk because we define our pressures very high. We rely on what I'll call short-term risk. All of our guidelines recommend around 10-year risk, and really it's risk for a lifetime. So especially if you're looking at somebody who's 40 or 50, they're likely to have high blood pressure for another 30 to 40 or 50 years. And lastly, we look at a limited number of outcomes. We don't think about blood pressure and its relationship to atrial fibrillation, to cognitive impairment, to many of the other complications that are ones that occur over a much longer period of time. Next slide. But we basically agree on what to do. We know from looking at trials and what we see in trials, and I'm showing that here in blue, and what we would predict as the benefit for lowering blood pressure from risk in cohort studies that almost all of the benefit from these drugs is lowering pressure. So the focus is not which drug you're using. The focus is, as Hart points out, get the blood pressure down. Pick the drugs you like as long as they're good combinations and focus on getting the blood pressure down. That's the key. Next slide. And we know just as risk goes up with higher levels of blood pressure, risk goes down as you get to lower levels of blood pressure. And I just want to show here, this is the top group here. We're looking at major cardiovascular outcomes. And it's comparing trials which have randomized people to less than 130 systolic versus higher pressure. Here's the line of identity. And I just want to point out here are 8 trials. Every single one of these trials is showing that the lower pressure that people are randomized to is better. It's universal. And we see the same thing when we look at less than 120 versus less than 140. Every single trial is suggesting the lower you can get that pressure, the better. There'll be 2 big trials coming out of Brazil. They're finished. And they'll help us. They'll be presented within, I imagine, the next year. And they will help us specifically in patients with diabetes and patients who are stroke survivors. But I just want to point out that benefit. It's also there for all-cause mortality. It's there for every single cardiovascular outcome: stroke, coronary heart disease, heart failure, cardiovascular mortality. And yes, there are some risk factors, but they're pretty modest and they're very infrequent. So when you weigh that balance between benefit and risk, it really tipped very strongly in favor of benefit. Next slide. Next slide, please. And I just want to point out that if we go back one time, thank you. I want to point out something that we've become very aware of in the recent past, and that is that most of the blood pressure effect of these antihypertensive drugs is present at low doses. There's very little difference between a quarter of the standard dose and the full dose. And we've done a meta-analysis, this one of several meta-analysis that I was involved in this one, nearly 500 randomized controlled trials comparing active treatment with placebo. And basically what it showed is with one drug, you're likely to get about 9 millimeters of mercury. You'll get a little more with diuretics. You'll get a little less with beta blockers. And obviously there's going to be individualization. Some people have a greater effect, but on average, you can assume about 9 millimeters. When you have 2 drugs, you can guess on average, you're going to get about 15 millimeters of mercury. As you go from lower dosage to higher dosage, you're going to get very little additional benefit. So the key here is adding complementary drugs from different classes of antihypertensive agents, not going up in dosage. And adverse events are very uncommon with these agents, but they tend to be linear. So as you go to those higher doses, you get more side effect and you get very little blood pressure benefit. And the last thing I want to say is that serious idiosyncratic reactions like anaphylaxis are extraordinarily uncommon. So it's very safe to combine these agents. So I think what Hartz does, starting with single pill combination therapy, makes tremendous sense. Next slide. Now, we've all said this. We know what to do. Every guideline agrees what to do. The guidelines are great in terms of evidence, but they're not very good in terms of getting it done. So the huge chasm is between what's in those guidelines and what's happening in practice. Next slide. And there are reasons for this. There are many barriers. I won't go through them all, but we can start with the patient. And, many patients are totally unaware that they have high blood pressure. They don't come in contact with the health system, so they don't get blood pressures measured. And it's silent. So it starts with awareness, and many people have unusual beliefs. Many people don't take the medications, and it's not necessarily their fault or all sorts of reasons. And there are all sorts of social determinants of health that get in the way of patients taking their treatment. And likewise, there are lots of barriers for clinicians, and they're providing good care. There are lots of barriers at the system level. We just make it very difficult to provide good care. Now, Kaiser Permanente would be an exception to this rule. They make it easy, but most systems make it difficult. And funding agencies, they make it difficult, and they just don't care very much. They're very interested in things that have short-term economic consequences. So hospitalization for heart failure will get their attention straight away. But chronic disease, where the outcome is going to occur over 20, 30, 40 years, doesn't get their attention. It's not high on their radar screen. So there are lots of barriers. Next slide. That's the bad news. Now, how does that translate? Well, in that report that I just mentioned, if you look at middle and low-income countries, almost 70% are either unaware of their diagnosis, and this is 140/90, a very high cut point, or they're aware but they've not been treated. That's shocking. 70%. And of those who are being treated, the vast majority aren't even getting their blood pressures below 140/90. And only slightly less than 14% were being treated on pressures under 140/90. Now, it's not all bad news, because compared to 2010, that's almost a doubling. It was 8.8% in 2010. So we're moving in the right direction, but we're not moving fast enough. And the high-income countries are doing better, but it's still not satisfactory, only 40% below 140/90. Again, that is an improvement over where we were, but I think we'll all agree we need to do more. Next slide, please. And the good news is we know how to get there. We know the barriers. We've identified them. We know things that facilitate treatment, and that's the beauty of hearts. It's a simple recipe that deals with barriers and encourages facilitation. Next slide. And I really have been, for many years, a very strong advocate of hearts, because when you look at the things that are successful for lowering blood pressure, they're almost all in the heart's recipe. So it starts with accurate and precise measurement of blood pressure. You've got to know where the blood pressure is to know how to manage it, and hearts puts a lot of emphasis on that. Got to start by recognizing that most people, like me, have uncomplicated hypertension. It's easy to manage. You don't need a specialist. You don't need individualization. You can take advantage of a team and distribute the responsibilities around the team. And if it's team-based and it's patient-centered and it's a convenient setting, you really increase the chances for success. Risk-based treatment is very useful, particularly in those who have less severe forms of hypertension. Do we need to add in medications? Health promotion lifestyle obviously underpins blood pressure, because that's what adverse lifestyle is what causes most high blood pressure. Simple evidence-based pharmacotherapy. Once daily, long-acting agents, single pill combinations, and access to affordable medication. These are the really important parts of pharmacotherapy. And again, Hearts focuses a lot of emphasis on that. Patient engagement is useful, and where it's possible, it's quite helpful to have home blood pressure monitoring. Not so much for the clinician to look at the measures, it can be useful, but more to engage the patient in their own care. And if we're engaging patients in their own care, they need to be trained how to measure blood pressure. And again, kudos to PAHO, because I think the PAHO course for training and certification for office blood pressure measurements and for home blood pressure measurements is by far the best that's out there. And it's a really, really good one. And that's what the World Hypertension recommends, or World Hypertension League. Monitoring and rapid case management when there are problems. We use milepost visits in many of the trials. It's not a feature of hearts, but it's very good for overcoming therapeutic inertia. And a milepost visit is a visit at which you say, it doesn't matter what the excuse is or the explanation for high blood pressure. If the pressure is high, we must add an additional agent from another class of antihypertensive therapy that makes sense as a complement. And it's really good for dealing with therapeutic inertia. Comorbidities, sometimes quite useful for getting blood pressure down. The classic example would be GLP-1 therapy for those with obesity or who have high blood pressure with a high BMI. But SGLT2s will bring pressure down a little. They're not enough to be identified as antihypertensive agents, but they'll get pressure down by about 5 millimeters of mercury. And then at the end, where it's very difficult, having access to a specialist for advice or for care makes a lot of sense in complicated hypertension and those who have true resistant hypertension. And most people have apparent, they don't really have resistant hypertension. They may seem to have it, but they either have white coat hypertension or they're not taking their medications or they're not following lifestyle recommendations. So most apparent resistant hypertension is not truly resistant to treatment. Next slide. So I'm just pointing out that in hearts, almost all of these things are in there. And I love the fact that, as everyone knows, hearts takes what's in the guidelines, especially what's in the WHO pharmacotherapy guideline. It creates a protocol and then it individualizes that to particular countries. It focuses on accurate blood pressure measurement. It focuses on risk management, and it focuses on single pill combination therapy from the outset. It's doing all the right things. It's absolutely the right recipe. Next slide. And I just want to go back to team-based care, which is a strong feature of hearts, and say that even in the most difficult to manage patients, team-based care has proven to be very helpful. And I want to point out that in just a few trials here, this is one from Argentina, and our colleagues from Argentina, Dr. Irazola and her colleagues, I think would agree with me that patients in the public health system in Argentina are notoriously difficult to manage, but with a simple team-based care approach like hearts, they got an additional close to 7 millimeters of mercury. In the US, we just published in New England Journal about 2 or 3 weeks ago a study done in patients with very difficult to manage blood pressure. They are being treated in what's called federally qualified health clinics. These are clinics that are put into communities where there is practically no access to care. And those who are being managed have lots of comorbidities. They have many social disadvantages. They have very little money. They have real problems with transportation. An additional nearly 7 millimeters of mercury. Now, Argentina and the US are different to China. In China, when you have a simple protocol and you tell people to follow it, everyone follows it. And a simple protocol in China got almost 20 millimeters of mercury. But I think in every one of these settings, whether it's a high-income country or it's a low-income country, that team-based approach, which Hearts emphasizes, has been very successful. Next slide. Next slide, please. And I couldn't be more excited now that we go into Hearts 2.0. And I think, again, kudos to PAHO, because you've got to start in the right place. You've got to start with blood pressure. You don't want to start with 5 different things because you're not going to be effective. You start with blood pressure and then you open it up to bring in the other risk predictors, and you try to deal with the cardiovascular-kidney-metabolic syndrome in a broader sense. And that's what Hearts 2.0 is doing, and I couldn't be more excited about the launch of the program. Next slide. So I want to say, in the end, congratulations to PAHO and to the entire Hearts in the Americas team. You have already accomplished what no one could have predicted 10 years ago. It's just extraordinary, and you should take great pride in what you've done. You've had very positive effect on many people's lives. You are the Hearts model for everybody else to emulate. Expanding the initiative to Hearts 2.0 is extraordinarily exciting. I understand it is incredibly challenging, but you will work the model out for everybody else, and you are a tremendous inspiration. And I take a great pride in being associated with PAHO and Hearts in America. I thank each and every one of you for all you do, and I wish you great success in implementation of Hearts Point 2, and thank you for the opportunity to be with you today.
Wow, thank you so much, Paul. Very proud of this commitment, very proud of you, very inspiring conversation. So I think that we are ready for the next. Paul Walton is an inspiration for the heart, and thank you so much. Well, to finish this section, Paul Mountainer, my co-moderator, a few words to close, the scientific, session of the Heart in the America webinar to go to the final where we have some surprise to finish. Thank you so much, Paul Walton. Go ahead, Paul Mountainer.
Okay, well, thank you. And Dr. Walton, a wonderful presentation as always. Starting with the review of the data and where we are with blood pressure levels, I think is a great place to start. And then transitioning to the successful strategies that we can take in terms of measurement, risk-based treatment, health promotion, engagement, milepost visits, etc. So really important, that slide on successful strategies. Taking it to the next level with the presentation and review of Hearts, taking guidelines, creating a protocol, tailoring it to the country, just so important. And then finally, the data on team-based care approach, very impressive trials and showing that can be done across different settings in Argentina, the US, China. And then finally, I want to reiterate what Dr. Walton closed with, which is just congratulations to PAHO. Congratulations to Hearts in the Americas. It really is truly a model to be emulated. And so very excited to see what comes next, but also very impressed with what has been done to date. And with that, I'll pass things back to you, Pedro.
Thank you very much. Well, muchas gracias de nuevo a todos y por la participación.
Thank you very much once again. Thank you for your participation. We have 2,400 people connected. It means that we have just lost 300 or 400 people. And now we're going to look at a very quick video, and then we will take a picture with the panelists so that you can have a souvenir of our meeting today. So if panelists want to turn on the video, they can do it now. Please go ahead. The Hearts window in the America, this facilitates access to the initiative. It's available to you in a single place, access from the Hearts webpage. And the initial part, you will see direct links that are currently updated guides, materials, training materials, and events that support the implementation of the model. We have the Hearts collection that gathers a scientific production as well as initiatives related to the initiative and its implementation. The collection has hundreds of documents and it is updated constantly. Most of the contents are open and free. You can use filters to explore by country, topic, language, and more. We invite you to explore the Hearts window in the Americas.
Bueno, Esto es lo que tenemos, la vitrina del conocimiento de Hart en las
This
Américas.
is
Hay más
what
de
we
100
have.
publicaciones.
The window,
Esto
the
lo ha hecho
windows,
Vireme,
the
Rosemary
window
y
of
a tu
hearts in the
equipo, al equipo de
Americas.
Vireme,
This
felicitaciones.
has been
Si
done by
lo que
Rosemary's
está
team.
faltando en la vitrina del
Congratulations.
conocimiento es
What is
que
missing in
más
the window
países se
of
sumen
knowledge
y
is for more
produzcan
countries to
más
join, to
conocimiento, que
produce
produzcan más
more
manuscritos, que
knowledge, produce
produzcan.
more
Tenemos el gusto de
papers,
decir que
documents.
ahora estamos trabajando también
We
con la
have the
revista
pleasure to say
panamericana de
that we
salud
are
pública, que va a
now
estar
also
publicando
working
un
with
número
the Pan
especial en
American
HART para el Día
Health
Mundial
Review.
del
It
Corazón, donde
will
están
be
participando múltiples países, pero
also
siempre le decimos a
participating
los
in
países,
the
ustedes quieren aparecer
World
en la
Heart
lista,
Day.
quieren
So
saber lo que
if
está
the countries
pasando,
want
lo
to
que
be in
están
the
haciendo,
list,
hay
if
que
they want to
publicar
know
los
what's
resultados de
happening,
la
what is
evaluación
being
que
done,
estamos
you have
haciendo
to
con HART,
publish the
cuál es el
results of the
impacto que
assessment that
estamos
we're doing with
teniendo.
Mark, what
Y
is
eso
the
hay que
impact that
llevarlo
we're
a
having,
publicaciones con
and we
peer
have to take
review, hay que
this
llevarlo a
to
publicaciones
publications
técnicas,
with peer
por eso
reviews, technical publications.
tenemos la vitrina del conocimiento
This
de
is
Hart
why
en las
we
Américas,
have
que es un
the
recurso
Hearts window in the
muy
Americas.
valioso para
This
que
is a
ustedes lo
very valuable
consulten. Ahí
resource
están
so that
todas
you
las
can
publicaciones
consult
de Hart
it.
en las
Here you
Américas,
have
así que
all the
yo
publications.
finalmente voy a hacer un ejercicio final, que es
And I
qué
will
nivel de
do a
aceptación
final
ha tenido este
exercise.
webinar.
What
Mariana, tú me
acceptance
pones
level
ahí el
has this
listado de
webinar
la
had?
gente de eso,
Mariana,
vamos a ver,
please.
Mariana.
You can put the
Vamos a
list on
ver,
the
siempre
screen.
hacemos una
Let's look at it.
evaluación de
We
cómo nos ha
always
ido,
do
de
an
qué ustedes quieren
assessment
escuchar, de
on
cuáles son
how
los temas que quieren poner,
well we've done to
del
see what
1
are the topics you want
al
to hear
9, al
about.
10, al
So
1 al 9, no te veo,
from
no veo bien.
1 to 9, from 1 to 10, I
No
don't
te
know.
escucho,
I
Mariana,
can't
estás
see
en
well
mute.
and I cannot hear you,
1
Mariana.
al
You
10,
are
póngalo en
muted.
el chat para que pueda
Please
aparecer
write
su,
in the
Entonces,
chat
su
del
from
ahorita
1 al
1 to
10,
numerito.
10.
del 1 al 10,
So
ustedes se
from
ponen
1
ahí
to
del 1
10.
al 10
Please
y
write on the chat
empezamos a
from 1
poner
to 10.
qué dice la gente de lo que hemos hecho. Esto
So
es
to
una
see what
evaluación en vivo,
people
¿no? ¿Qué dice
say
la
about what
audiencia de
we've done. What does the
2.500
audience
personas
say?
evaluando
This
un panel
2,500 audience. What does this 2,500 people
o sea,
audience
no se vale
says
15 porque hay
say
muchos
about
15,
this
15 no se
panel,
vale.
this event?
Y 0 no lo
You
tenemos
cannot
en cuenta,
put
así que no están incluidos 0 y
15, and
15.
we will not
Así
take into
que
account 0.
pueden ponerlo en números,
So you can
que es
put
la
it
manera
in
más fácil
numbers,
de hacer
okay? This
esto.
is the easiest
2.500
way to do
personas
this.
han estado escuchando han estado viendo
2,500
este
people
webinar.
have been
Quiero decirles
listening
que
and watching this
como tenemos
webinar.
todos los correos de ustedes, como se
We have
inscribieron al
your
webinar,
emails
ustedes van a
because you
recibir
were
la
inscribed in the
colección
webinar.
completa
And so
de
you're
los
going to
papers, de
receive
la
the full
grabación,
collection of the
para que la
papers. You're
tengan,
going to
para que la
receive
puedan
the
compartir con sus
recording
colegas,
so
con
that you
los
can share it
profesores, para
with
que la puedan
your
compartir con
networks,
sus alumnos,
so
la
that you can
gente,
share
para
it
que
with your
pueda
students, if
compartirla con
you're
su
a teacher,
network,
professor,
¿no? Estamos muy
and so
orgullosos
that
de
you
lo que
can
hemos
share with
hecho
your
aquí. Hemos
whole
tenido un
network. We're
panel
very
tremendo.
proud of what we've done here. We've had
No sé
an
qué tiempo más
amazing
vamos a estar
panel.
votando porque hay gente que se quedaron ahí al final, pero quiero que al final tengamos todos los
And I
panelistas
would
solamente
like
la foto y entonces
to have
lo que
a
podemos
final
hacer es, si
picture of
ustedes desde
everyone
su
in the
casa
panelists.
pueden hacer así, se pone o
From
desde
your
donde estén,
house, you can
pone
do
su
this.
teléfono,
You
así
can
como estoy
take your
haciéndolo yo,
phone, like I'm doing.
y van a buscar y se van a poner así y van a
Then
encontrar y decir,
you
mira la foto que me voy a tirar
take your
con los
phone in this
panelistas
position, and then you
estelares
take
que
a
hemos tenido
photo
aquí en el
of
día, que son dos
yourselves
personas
with the
de
panelists.
primer nivel. Y eso, si yo fuera un
We've
muchacho más
had
joven, me
amazing
encantaría.
panelists, and
Todavía soy
if
un
I
muchacho joven.
was younger,
Me
I would love to
encantaría
take a picture of myself with the
tirarme la
panelists.
foto con
Actually, I'm still a young
súper
person.
grupo de expertos. Mariana, ¿tenemos unas
I
conclusiones
would
o
like
todavía?
to take my picture with the panelists.
Vamos a ver.
Mariana, do we have a conclusion
A ver,
regarding
¿la
our
podemos
score?
poner o no?
Sí, sí.
Can we put it on the
A
screen?
ver.
Yes.
Vamos a ver qué dice el público.
Let's see what the public says.
Yes.
No puede ser. No puede
10.
ser. Eso no puede ser.
Impossible.
Sí.
Really?
Bueno,
Yes.
bueno, entonces si es verdad que la gente está
Very
dándonos 10,
good. So
yo creo que
if
hemos hecho el
people
trabajo
have given us a
hoy.
10,
Los
I
panelistas se
believe
pueden
that
sentir
we've
muy
done
felices, muy
great
positivos.
work
Entonces,
today.
vamos a
The
poner la
panelists
foto
can
entonces
feel
en
very
la primera
happy. And so
plana.
now
La
let's take a
producción,
picture.
ponemos la foto de nuestros
Let's take
panelistas.
a picture of our
Mariana,
panelists.
sí, Mariana está en la superproducción ahí,
Mariana.
Libardo Rodríguez, los
Mariana is taking
intérpretes,
care of the super
Andrés Rosende.
production.
Nosotros no somos
The
muchos,
panelists, the
pero
interpreters.
tocamos mucho, tenemos que tocar todos los instrumentos porque no tenemos con qué, así que
We are not a big team, but we have to do everything.
Tiramos la foto, podemos acercarnos la cámara, Mariana,
Can we get closer to the camera
Tenemos la
so that
foto.
we are all on the first page?
Vale, muy bien, muy bien. Bueno,
Well,
gracias a todos los panelistas. Gracias,
thanks to
Paul,
all
por
the
esta aventura,
panelists. Thank you,
como
Paul, for
moderador
this
de
adventure.
esta sesión
Thank you
de
for
Heart in
being
America.
the co-moderator of this
Muchas
heart
gracias a
session
ti,
in the
Alejandro
Americas.
Ferreiro, Esteban, Ricardo,
Oh, well done, Alejandro, Ferreiro, Andres, everyone. Thank you for being so nice. Thank you for being with us. And thank you to the public for resisting for 2 hours during this event. Thank you very much. And happy Global Hypertension Day.
Around the world, cardiovascular diseases are the leading cause of death. But so many of these lives could be saved with better control of hypertension. If we could raise population control from 36 to 50%, we would prevent nearly 440,000 deaths and almost 3 million cardiovascular events. From the global vision of the World Health Organization came HEARTS. The Pan American Health Organization, with leadership from the Ministries of Health of the region, expanded that vision into HEARTS in the Americas, a strategy for quality improvement. Today, 34 countries are committed. More than 11,000 health centers are implementing HEARTS, reaching 50 million adults. We are transforming primary health care with the HEARTS clinical pathway, promoting team-based care and the use of data for continuous cycles of improvement. In 2026, over 7 million adults are receiving treatment, and more than half already have their blood pressure under control. But our story is still being written. Over 200 million adults in the Americas live with hypertension. And our goal is clear, that everyone has access to better care. This is HEARTS in the Americas.
Muchísimas gracias. Ahora sí nos despedimos. Que tengan un buen día.
Thank you very much. We now say goodbye. Have a great day. See you soon.